You can start, Dr. Muhammad. Dr. Muhammad, you can start.
Yes, yeah,
We
you
are
can
ready.
hear me?
Yes, we are ready. You can start now.
Yeah. So good afternoon, everybody. It's our great honor to be here with the joints of glaucoma surgery from different countries around the world. And the webinar will be about glaucoma drainage devices. Will focus mainly about tube shunt surgeries. So the speakers will be Dr. Tachin Peter Chanj, Associated Professor Clinical Ophthalmology, Pediatric and Genetics from Bascom Palmer Eye Institute, Miami, India. And Dr. George V. Pothrin, HOD Glaucoma Services, Aravind Eye Hospital, Madurai, India, is expert in doing Orolab aqueous drainage implant mainly. And Prof. Wissam Shahada, Professor of Ophthalmology and Dean at Faculty of Medicine, Yarmouk University, Amman, Jordan, one of the key figures in the glaucoma surgeries at Jordan. And Dr. Sricha Senthil, Head VSC Glaucoma Services at LV Prasad Eye Institute, Hyderabad. I got a chance to be observer with her, and she is one of the best surgeons I have ever seen. And Dr. Meena Menon, HOD Glaucoma Services, Sankara Eye Hospital, Bangalore, India. She was my mentor during my glaucoma fellowship. And so it's a great chance to be here with us, Dr. Meena. And Prof. Yasmina Sayed, Professor of Ophthalmology, Cairo University, Egypt. She's one of the famous surgeons in glaucoma surgery in Egypt and Middle East. So welcome all, and we'll start with Dr. Peter. He will speak about tube shunt basic.
Great, thank you very much
Start,
for
Dr.
the introduction. Let me share my screen. Okay, are you able to see my screen?
Yes, we can see.
Great, okay, let me just minimize this window. Okay, good afternoon and good evening to everyone. This is a real pleasure to be able to share with you my glaucoma drainage device implantation technique. And I'm honored to be joining such a distinguished international panel today. And I thank the organizers for putting me first just to take some of the pressure off of public speaking. Here are my financial disclosures. They do not pertain to the content of the presentation you're about to hear. And as far as format, what I like to do is to first talk about the steps that I use in doing a tube shunt implant, followed by a video showing the steps. And in particular, I know we have speakers who will be focusing on placing a tube shunt in children. So I decided I'm going to focus on adults. And also we are about to hear another excellent talk about a valve implant. So I decided to focus on a non-valve bar valve implant. So this will be about bar valve 350 implant in an adult. So to start the surgery, one of course have to first make a peritomy. I do a large peritomy of about 5 clock hours, and I place a traction suture behind the incision line. I then put the plate under the muscles and I fixate with AO nylon. And here are the surgical steps. So as you can see, the peritomy is quite large, and I put a limboscleral traction suture behind the incision line for two reasons. One, I like to avoid putting a needle track through the clear cornea to prevent infection. And number two, this suture can serve to close the conjunctiva at the end. After I'm able to dissect a large pocket, I will isolate the respective muscles. This is, of course, an infranasal bar valve, so this is the medial rectus muscle. I place the bar valve sideways first, then I make a 90-degree turn as shown here to place it under the medial rectus muscle. and I will isolate the inferior rectus muscle here, and I can position the second wing of the barbell squarely underneath the inferior rectus muscle. And when fixating the plate, I use the AO nylon suture. I like to place a scleral bite first. Afterwards, I will feed the suture blunt end first through the eyelet of the plate. Why do I do this? Well, there are two advantages. Number one, if you do the scleral bite first, followed by threading the suture through the plate, when you tie the knot automatically ends up underneath the plate, which saves me from having to rotate the knot and risk accidentally breaking the suture in this very delicate step. So you can see the knot is under the plate already. And we'll see that again. I'm doing a scleral bite here, and you will see that I reload the needle such that I'm grabbing at the sharp tip, and I will introduce a blunt end first through the eyelet. And this is very safe because then I do not have to worry about accidentally penetrating the globe with the sharp needle when I'm passing it through the eyelet. And again, here's a triple throw, and the knot automatically ends up underneath the plate. So this is a fairly time-saving technique to use. So now that the plate has been fixated onto the globe, we need to flush the tube to make sure it's patent. Then we need to ligate it. In a non-valve tube, we have to ligate it to prevent flat chamber and hypotony. And my ligature of choice is the 7/0 Vicryl suture. I use what I call the bubble test to make sure the ligation and the occlusion is complete, which I'll demonstrate in a little bit. And I do place a bevel away from the iris. I do my needle track using what's called the needle wiggle technique, and I anchor the tube down onto the sclera after it's been placed into the eye using a ski track configuration. So the first thing I like to do is to tuck the tube underneath one of the speculum prongs, which frees up my hand and actually makes the tube more manageable. And we flush this so it's patent. Here's the ligature. We're going to do a triple throw. And upon closing, I'm very firmly and gently tugging on the suture until the lumen collapses. And what I will do next is to take a pair of tires, and you'll see a swiping motion, or I'm going to squeeze out some of the fluid inside the tube and allow a bubble to enter. So when I hook this up to a cannula of BSS, as shown here, and when I try to inject the BSS, you will observe the bubble traveling and bouncing in the lumen of the tube, but it does not go downstream. So right here, just focus. You see the bubble moving, but it does not go downstream. And this is a very reassuring sign that my occlusion is complete and adequate as to prevent early hypotony and a flat chamber. So of course, I tie off my ligature with 2 additional throws. And then what we need to do is to make sure the length of the tube is adequate and that it has an adequate bevel. I put the eye in primary position. Now this is a pseudophakic patient. The tube is going to the sulcus. So there's a posterior pointing bevel to point it away from the iris. And here I engage the needle in the scleral groove. You see, I'm just wiggling the needle. I'm not pushing. And usually the cutting bevel of the 23 gauge needle will guide the needle very smoothly into a plane that I want, like such. And this goes for a very controlled entry of the needle. The thing we want to avoid is a sudden entry where we can accidentally damage the lens. And this is a very safe technique to do when we're working with trainees. So once the tube is in the eye, we check its position. It's adequate. It's in the sulcus. I like to pull back a little bit so that I only see a little bit of the tube tips through the dilated pupil. And to anchor the tube, I use an AO nylon suture. I prefer what I call a ski track configuration where the 2 passes are in opposite directions. So here's a forehand pass. I'm going to do a backhand pass now. And the advantage of this over a figure of 8 suture is that the AO nylon suture will anchor the tube in 2 spots instead of 1. A figure of 8 will only anchor the tube where the 2 sutures cross, but this provides 2 points of anchoring. And you can see the tube is very secure on the sclera. And it's anchored right here and right here. So now the tube is inside the eye. We need to fenestrate the tube to provide early pressure release. Now in my hands, I use a 7.0 Vicro needle. One fenestration in general lowers the pressure about 10 millimeters of mercury. And I don't do more than 2 fenestrations because then the pressure lowering becomes inconsistent and unpredictable. If I need to lower the pressure more than 20 millimeters of mercury, for example, in a patient with neovascular glaucoma, I would either implant a valve tube like an Ahmed valve, or more commonly, I would do a concurrent trabeculectomy, and this is one of the variations I'll demonstrate later. I do use a patch graft. I know we're about to hear an excellent talk about patch-free tube implant, and I'm looking forward to learning that technique. And then I close the conjunctiva with 7.0 Vicro sutures. So here I have in my hand the needle of a 7.0 Vicro. I'm making a fenestration. I penetrate the tube and I slice it about 1 needle width over so that the entire fenestration is 2 needle width. And this is what I'm looking for. I'm looking for aqueous to egress very slowly with a little bead along the tube wall. And with that, I'm fairly confident I will get approximately 10 millimeters of mercury of lowering per fenestration. So this person should have about 20 millimeter mercury lowering of pressure. Now that the fenestration is done, we'll secure the patch graft. I'm using a half thickness semilunar corneal graft here that's procured by our Eye Institute's eye bank. And I prefer the patch graft to be sutured fairly tightly to prevent migration and use the 2-point fixation technique. And to close the conjunctiva, there are many different ways. Because I work mostly with children, I have committed to using just interrupted sutures instead of running sutures. And that way, if one of the knots become loose, I do not have the risk of the entire surgical wound splitting open. And I also take care to always bury my knots. I will enter the wound with my suture to make sure that the knot ends up underneath the conjunctiva, because the patient is much more comfortable. And in young patients, this is the difference between being able to examine the child with a slit lamp versus having to do an exam under anesthesia. And lastly, as you can see here, my original traction suture, I released it and now it turns into a ready placed horizontal mattress suture, which I can use to prevent conjunctival retraction over the area of the tube implantation. And so that is the entire procedure itself. Now I'm going to cover 2 slight variations to this technique. The first one, which I've alluded to a little bit earlier, is the placement of a concurrent orphan trabeculectomy. When do I do this? Well, as we mentioned, when we need immediate pressure lowering of greater than 20 millimeters of mercury, or when I really need the pressure lowering to be titratable in a stepwise fashion. And here's the technique. Up until the part of the trabeculectomy, the surgical procedure is identical to the videos that you have just seen. But here are the additional steps. So here I'm making 1 scleral groove for the tube. I'm making a 2nd scleral groove for the trabeculectomy. Now, my trabeculectomy technique was taught to me by my mentor, Dr. Paul Pomberg, and we perform a scleral groove valve-like incision technique as opposed to a scleral tunnel. So that might be a little bit different than what you're used to seeing. And once I finish the scleral dissection, here I'm using the needle wiggle technique to put the tube into the eye. This one's going into the anterior chamber. And now once the tube is in the eye, we secure it to the sclera and we place a patch graft just like the previous videos. And now we're going to work on the trabeculectomy. I also like to use the anterior chamber maintainer. This is a technique taught to me by Professor Peng Kao in Moorfields. And here I'm entering the eye through the scleral tunnel, and the posterior lip of the tunnel is punched to create a sclerostomy. And we do a iridectomy. All of this is standard. And I like to close my trabeculectomy using releasable sutures with just a little bit of flow. And we close the conjunctiva using a standard technique. And this particular patient is actually a child with very high pressure. And what you can see is we already have a very exuberant blood forming. The pressure is very adequate, estimated to be between 10 and 15, and the anterior chamber is very deep. And in the upcoming weeks prior to the tube opening, which usually takes about 5 weeks or so, If I need to lower the pressure further, I can simply pull on these releasable suture loops to open the trabeculectomy further. That gives me exquisite pressure control in the post-op period. Now, the last thing I want to cover is another variation that helps me visualize the tube tip through the opaque cornea. And the typical scenario would be a patient pending a corneal transplant who needs a tube shunt for pressure control before they can have the corneal transplant surgery. And as you can see here, we put the tube into the eye. Again, this is the inferior tube, but the cornea is in such bad shape that you can't really tell where the tube is. Is it in the AC, in the sulcus, or perhaps gone into the pars plana? And one of the techniques that I find very useful is to take a light pipe like this, and you can see the tube right there. And to verify its position, we can actually tap on the base of the tube. And you can see right here, very briefly, that it moves. And then that makes the surgical outcome much more predictable. And it's a very useful technique when the corneal condition is not good enough for you to verify the position of the tube tip. So that is the end of my talk. I beg your indulgence. I want to share with you some summaries. First, we discussed how I place a limbal traction suture behind the incision line rather than doing corneal traction suture. After ligation, I do a bubble test to make sure the tube is completely occluded to prevent early hypotony and flat chamber. I use the wiggle technique to create my needle track for controlled entry into the eye. For fenestration in my hands, using a 7.0 Vicryl suture needle, each fenestration gives me about 10 millimeters of mercury, so pressure reduction. I close my conjunctiva using only interrupted sutures, and I bury all knots. And we discussed the two variations. One is the orphan trabeculectomy that allows the titratable postoperative pressure management. And lastly, using oblique illumination to visualize the tube tip through opaque cornea. And very lastly, I do have a very modest YouTube channel where I upload all my surgical videos. And if you end up watching some of these and have any comments on how the surgery can be done better, please feel free to comment, because I love to learn from everybody to see how I can improve my own surgical outcome. And lastly, I want to make aware that there is a free resource. This textbook that myself and Drs. Ramulu and Hoda have authored is now free as a PDF file that is being housed at the American Academy of Ophthalmology website. So if you take a picture of this QR code, you will be directed directly to this PDF file. And this is meant for non-glaucoma specialists, so please feel free to share it with your comprehensive ophthalmology colleagues and to all your trainees. And thank you very much for your time.
Thank you very much, Dr. Peter. Just I have a question for you that once you are doing, combined AGV with, tube with trabeculectomy, how common the chance of complications will happen, like hypotony or something?
Actually, not very common. I still fenestrate the tube, and I tend to tie the trabeculectomy sutures a little bit tighter than just a regular trabeculectomy. I think of the trabeculectomy as a backup, as a titratable plan B if I need it. I'm not looking for a high flow trabeculectomy when I do a combined procedure like that.
And if once you are doing fenestration, it's enough to bring the IOP immediately low post-op?
Yes. So I did a retrospective review of my own cases, and fairly consistently, the pressure usually lowers about 10. Now, the trick also, some of the common mistakes that my trainees and myself have made is we should not put the fenestration in any part of the tube that has a bend. It has to be the straight part of the tube, because if you put it at the bend, the fenestration will fish mouth open and you can get hypotony that way. And number two, the control of the fenestration has to be perfect. If as you enter and leave the tube lumen, you move in such a wrong way where the fenestration is not a straight line, but maybe either a smiley face or a frown, then the fenestration can fish mouth and you can get hypotony.
Thank you very much, Dr. Peter.
Thank you.
I have a question. Thanks, Dr. Chen, for the nice talk. I have a question. What is your post-operative course for drops after the tube implantation?
So I put them on topical prednisolone 4 times a day and topical atropine once a day until the tube opens. So I do not taper or discontinue either one of those until about 5 to 6 weeks later. I put them on topical antibiotics from 7 to 10 days. And depends on what their postoperative pressure is and what their target pressure is, I may or may not resume their glaucoma medications. In adults, I see them at 1 week, and every week or every other week, depends on the severity of their glaucoma, to monitor for pressure spike. In young children, I will see them at 1 week, see them at 4 weeks, and I do another exam under anesthesia at 8 weeks.
Great. I have also another question. When you do the combined trab with tube, do you use a mitomycin like sponges or injection? Or
neither. So when I commit them to a tube shunt, I do not use mitomycin. And my fear is that they can have exposure of the tube shunt if the conjunctiva is compromised with antifibrotic.
No, even with combined with trab, you don't use mitomycin. No, correct. Great, thanks. And let's see questions. Any other questions? So now we can move to the next lecture with Dr. George. He's going to speak about the patch-free tube implantation.
You can just unmute your. Okay.
Okay, thank you. I'm audible?
Yes, Dr. George. Yeah. Yes, we can hear you. Yes.
Yeah, and wonderful presentation, Dr. Chang. We really enjoyed. So this is Professor Paul Pomberg from the Vascom Palmer Eye Institute, Miami, who has made multiple visits to Madurai. And during one of his visits, he was involved with assisting for the surgical training of an affordable non-valved aqueous drainage implant. And during one of his visits to Madurai, he started advocating a patch-free tube implantation. And he kept referring to this article, which was published by the Felix Gill group from Mexico. And it appeared in the Indian Journal of Ophthalmology about 10 years back. So they have described a technique of a needle-generated scleral track without fashioning a scleral flap or using a donor patch graft. And they looked at about 128 Mexican pediatric eyes over a mean follow-up of 2 years. They had some tube-related problems like tube retraction, tube corneal touch, and tube lens touch. But what was very impressive in this publication was there were no tube extrusions nor any tube exposures with this technique. And mind you, these are pediatric refractory glaucomas. So the patch-free tube implantation, we are going to discuss the surgical technique. So we mark the tube is draped over the cornea, and 2 millimeters anterior mark is placed on the tube, and you fashion an good anterior bevel at the mark. Again, use of a Castrovillo straight caliper and also a marking pen. The initial groove to start your scleral track is marked beforehand. So this is 4 millimeter posterior to the limbus and 2 millimeter medial to the original position of the tube. So just note what the surgeon is trying to do. He's trying to keep the groove of the needle above the track, and I will discuss this in detail a little later. So a bent 23 gauge needle is used to initiate the scleral track. So we aim to have approximately 50% of scleral depth shown by its visibility of the needle throughout, and the needle is progressively advanced forwards till about 3/4 of the way to the corneal edge. We need to dramatically change the position of the needle. Here, initially, it was just a tunneling motion. And once we reach a particular point, the needle has to be dipped directly into the anterior chamber. This needs to be parallel to the iris plane and as close to the iris as possible. So counter traction by holding the cut edge of the conjunctiva with a corneal forceps, slightly rotating the eye towards from a relatively downward position to looking straight ahead will help the surgeon to see the needle clearly in the anterior chamber. So the needle, the tube with an anterior bevel is now threaded in through the scleral tract. Till it is visualized in the anterior chamber. You need to visualize an optimum 2 millimeter length of the tube in the anterior chamber. So your length of the scleral tract has to be a minimum of 4 millimeters. So it's close to 5 millimeter here. And then the conjunctiva is meticulously closed, making sure that you involve the Tenon's fascia also. So once you have your tube embedded in the patient's own sclera, the elevation is much less. It's a much smoother ocular surface, leading to a much better wound healing and lesser of inflammation. But the caveat here is that you need to have a scleral tract which is sufficiently long and of sufficient depth so that the tube is embedded well in the patient's own tissue. So the Felix Gill paper describes a 22 or a 23 gauge, 3 to 4 millimeter long needle tract. And what we have slightly modified here is that to mark the tube. So we marked 2 millimeter tube anterior to the limbus before we trim the tube. And also we carefully mark the initial scleral groove. This ensures an optimal 2 millimeter length of the tube in the anterior chamber and also ensures there's a minimum 4 millimeter scleral tract for the tube implantation. And another modification is whether it's the right eye or the left eye, the scleral tract is positioned medially and tubes enter the eye around 12 o'clock. So the advantage here is most of these tubes lie around approximately at the 12 o'clock position, minimizes the contact with the superior eyelid. Again, and the risk of tube exposure might be minimized. Again, there are multiple advantages of this initial sinuous route. For example, if you need to do a secondary interventions later on for a tube exposure or for a tube retraction or for a tube corneal touch, what we have found is we have adequate length of the tube still available. This was a monocular child who had unfortunately had a tube retraction. Even on gonioscopy, we could not make out the tube. So this is the initial route. At 12 o'clock, the tube goes here and you don't find it in the anterior chamber. And I'll just fast forward this a little bit so that we still remain relevant to this talk. Yeah. So now we have got the tube out of the eye. If you see carefully, this is the straight track. And this was the initial sinuous route. So again, 4 millimeter posteriorly, make a new track. This is the left eye. So we go lateral aspect. So that's the initial position of the tube. And it's the same procedure. But what I want to highlight here is that what we do is we keep the needle above the scleral tract and prejudge the position beforehand. This is a little bit of mental calculation, a little bit of experience. Depending on the anterior chamber depth, we have to make sure where we have to change the position of the needle from tunneling motion to a direct entry into the anterior chamber. So what we have noted is if we have a 4 millimeter track, usually if you have the entire groove of the needle into the track, that is almost always the position where you have to lift up your needle and dip into the anterior chamber. And the aim is to have the tube enter the eye probably through the trabecular meshwork, but definitely below the scleral spur. So there you see the tube is there in the anterior chamber. So, and So basically, tube extension has been taken out of the equation in many of our patients requiring secondary interventions. So this is about 6 months post-operative. You could see the tube in the anterior chamber. So another big advantage we have seen is the transition from the conjunctiva of the cornea at the limbus is very smooth. So this again leads to much better tear film stability there, better lubrication, and we don't see those sometimes painful blebs or delents which are associated with patch grafts. And probably this also is another reason why minimizes the risk of tube exposure. So initially, at first, to make a long scleral track and also to pass the flexible tube through the track can be difficult, but we should keep in mind that these are long scleral tracks that are self-sealing and it is amenable to a second needle pass. Another advantage is micro movements of it's a snug fit of the tube in the scleral track. Micro movements can be avoided. So aberrations, tube movements, have been reasons postulated for late tube exposures. Again, another advantage is late tube straightening, which can lead to tubes being positioned closer to the endothelium at a later postoperative date, can also be minimized because the resistance to tube straightening is distributed over a much longer scleral track. So we have had recently our results with this technique published entitled Orolab Aqueous Drainage Implant with and without scleral patch graft in refractory adult and pediatric glaucomas, a comparative study published very recently in the American Journal of Ophthalmology. And it has this article also has a link to a supplemental video. We have tried to describe the surgical technique as best as we possibly could. And there is a lot of experience and knowledge of Professor Palmberg that has gone into the discussion part, also very, very useful practical tips in the discussion. So what we looked at was, this is a retrospective comparative interventional case series. We looked at 215 adult eyes, 147 were in the patch group, 68 patients did not receive the patch, 111 pediatric eyes, 73 children received the patch graft, 38 children did not receive one. And we looked at patients who had completed a minimum follow-up of 2 years. And naturally, the numbers are much lesser for the non-patch group. And the follow-up is also lesser because we started this technique after January 2016. There were no differences in mean intraocular pressure, visual acuity, or the need for IOP lowering medications in both the groups. The number of complications were comparable in both the patch and the no patch group. Cumulative success rates at 2 years in adults were similar to those in children with both techniques. But what we are really looking at was the rate of tube exposure. So we found 2 tube exposures in the adult group who received the patch graft versus no exposure in the non-patch group. Again, in the pediatric eyes, 7 patients who received the patch graft had tube exposure, and none of them had. It was very encouraging to note that tube exposures were not present in the no patch group. So the 2 eyes which received the patch and who had tube exposures, one of the patient had a tube exposure at the 1st month post-operative visit, and the second patient was in the 6th month post-operative. Pediatric eyes, 5 of them were within the first 10 months. The 2 eyes which had a tube exposure later, one was at the 40th month where this patient had progressive high intraocular pressure, endothelial touch, and finally tube exposure. And one at the 56th month where it was patch melt and tube exposure. So basically, tube exposure is of paramount importance when we try to implant a tube without a patch graft. And this is precisely the reason why this technique has been much less studied in literature. And I am sure most of the panelists in this group will agree that patch grafts also generally tend to melt over time. And if you see some of the eyes have total patch graft melt, and they just remain stable with this conjunctiva overlying the conjunctiva overlying the tube. This is of course very rare, but this is just to show that even patch grafts can melt and tubes can expose. So some practical tips before I finish. It's very important to ensure that your plate is fixed at the correct position before you mark the tube. Because of all this manipulation with the tenons and the conjunctiva, sometimes there is a risk that your plate might be artificially moving a little forwards, and then you're marking the tube 2 millimeter. And then you position your plate back, and you know you would have insufficient length of the tube to implant in this surgical technique. And another thing is, once you have had 50%, once you've initiated 50% scleral, approximately 50% scleral depth while initiating the scleral track, it's always good to have an upward lift on the syringe while progressively moving it forward. This tends to save you from going too deep and sometimes injuring the iris or going into the sulcus. Another thing we have noticed is, suppose you inadvertently lean on the needle while you advance it forward, you tend to go much closer to the endothelium. Again, very, very important, prejudge the point of transition of the needle pass at the limbus. I have told you that we have to prejudge where the needle pass abruptly changes into the direct dip into the anterior chamber. Again, a good anterior bevel can actually be of great help to introduce this tube through this long scleral track. And sometimes we see that we get stuck somewhere near where the transition occurs. The tube doesn't go forward. And we have seen that depressing the limbus with a second instrument facilitates movement of the tube beyond this point. And as for any other surgery, having access to a wet lab will go a long way in practicing and perfecting this technique before actually you practice this, you try this in the OR. And if you have access to a single cadaveric eye, you could make n number of these tracks to get an idea of what is to be done. And to conclude, the results in literature, there are very minimal tube exposures have been reported in literature with this technique, and corroborated by our present findings. It's encouraging, and seems that glaucoma surgeons could adopt this technique going forward, which would ultimately would lead to more widespread use of glaucoma drainage devices at potentially low cost. Thank you very much.
Thank you very much, Dr. George, for this nice presentation and very amazing technique. Just the only thing that we are worried about mainly is tube exposure. This is the only thing. Just all of glaucoma surgeons are worried. I mean, during tube implantation, that tube exposure, or how common is the tube exposure? And so if you just compare to scleral graft or corneal graft, you find that tube exposure will be less in this technique?
That's what literature says. If you look at most of the literature with tubes, tube exposures rate reach up to 10%. And if you look at, and people have tried to modify this technique for various reasons. One of them was availability to a patch material, cost factor, risk of infections being transmitted. So many of the surgeons in literature have tried various techniques. They have may not be the same one, but if you look at literature, even though the literature is less, the tube exposures for this patch-free technique is about 3% compared to almost touching 10% with the patch technique. The reason why, another reason is that people, I think surgeons are a little skeptical of doing a tube implantation without patch graft. But then that is also the reason why this technique has not been studied well in the literature.
Thank you, Dr. One more question that I want to ask you: how common you are using valve or non-valve implant?
So basically, we prefer to use the non-valve implant because we have access to it. We are comfortable with it. The only indication we would prefer to have a non-valve, a valve implant would be when there is a very high risk of ocular hypertonic causing sudden visual deterioration. So that is one indication where we don't want to risk hypotony. Probably a very elderly with significant visual field loss, we would use a non-valve implant. some of the patients like the uveitic glaucoma, which are highly predisposed to ocular hypotony following any kind of intraocular surgery for glaucoma, we would still prefer to use the valved implant. And Dr. Chang was mentioning about the neovascular glaucoma. If you need sudden reduction of intraocular pressure, probably a non-valved implant would be a better choice. But again, you could get over the initial phase of high pressures with venting slits and aqueous suppressants. And probably in the long run, the advantages of a non-valved implant would be better than having those. Many of them end up with localized encapsulated blebs with the valved implants. Does it answer your question?
Yes, yes. Thank you, Dr. George.
Can I ask a question, Dr. Muhammad?
Yes, you can.
Thank you very much for the wonderful presentation. I'm sure it's an excellent technique, and I'm really willing to try it. I was wondering, do you feel comfortable doing this on all kinds of eyes? I mean, are there eyes where you say, no, it's safer to go for a patch, like high myopes, people with the thin sclera, or others?
To be very frank, I have not needed this a patch for patients using this technique. But suppose you have while fashioning the scleral tract, you have some damage to the scleral tract while withdrawing the needle, because you want the tube to be snugly fit there. You don't want immediate peritubular filtration. So in that kind of situation, probably you might need to use a patch graft, but I don't think. But once you have adequate scleral thickness to fashion this long scleral tract, I don't think we require a patch graft to cover the tube. And most of these tube exposures occur in the first 4 millimeter near the limbus.
Okay.
Having the tube very well embedded in the patient's sclera, there are multiple advantages that have been told in the literature, that have been alluded to. So once you have this tube nicely embedded in the patient's sclera, the risk of tube exposure, probably having a patch and you have this elevation and constant rubbing and micro movements, those are probably may predispose more to tube exposures.
Thank you.
I have a question, Dr. George. Thanks for the nice presentation as well. You're using this technique with both, also with valved tubes, or just with the non-valved, the scleral tunneling?
It doesn't matter, no? For any glaucoma, yeah, it doesn't matter. So for any glaucoma drainage device, this is our go-to technique for the time being.
Okay, and if you find that the tube inside the AC is much longer, do you have any difficulty when you cut the tube shorter and going in the tunnel again? Any problems, or like if you?
So if you accurately mark the tube 2 millimeters from the limbus and then go 2 millimeters medial to the original position, approximately, that's another big advantage of this technique. You mark the tube exactly at 2 millimeter, get your anterior bevel get the anterior bevel at the tube, at the mark, and then you insert it 2 millimeter medial to the position, actual position, you get 2 millimeters of tube in the anterior chamber. Suppose you have a long tube, it's very easy, self-sealing, you just remove the tube, trim it and put it back and place it back.
Oh, great. Any other questions before we move to the next talk?
If anyone from the panelists want to ask a question, he can ask.
Okay, so it seems no more questions. So thanks, Dr. George, for the nice talk. We'll move now to the next speaker, Dr. Surisha. We'll talk about glaucoma drainage devices in pediatric glaucoma.
Excuse me, Dr. Nawaf. Could please the presenter to when you are going to share the screen, just click on the square for make it as video presentation, because the video presentation will make it smooth for videos, and it will not be frame by frame. Yeah.
So
when you are going to click the share screen, okay, you will find the desktop and then the presentation. Down you will find the square with make it as video presentation.
There's a defined sharing option. Multiple participant.
No, when you are going to share the screen itself, when you are pressing share screen.
Oh, okay. Yeah, I'm not. I mean, I'm not the one who presented, Dr.
No. Anyone who from the presenters.
Okay. Oh, okay.
This is because of the video. If it is not as video presentation, it will be frame by frame.
Frame by frame.
Interrupted
Okay.
frames.
Okay.
This is due to Dr. Srisha, I think.
Yeah, so let me just try that.
Yes. Before you share the screen, you click on the PowerPoint presentation. You will find the square down, make as video presentation.
Okay, 1 second. All right, so
Optimize the screen sharing for video clip. Once you press the green button for share screen, okay,
yes.
you will find the screen and then whiteboard, iPad, and down you will find 2 squares, empty squares.
Yes,
Share
optimize
for
yeah, video.
Make it optimized for video clip, yeah.
Okay.
And then click share.
Fantastic. Are you able to see the presentation now?
Yes, okay.
Yes.
You can proceed, yes.
All right. Okay, so thank you so much for the invitation and 2 fantastic talks. So I'll take you through the use of glaucoma drainage devices in pediatric glaucoma. So I have no financial disclosures to make. So I'll just start with a case. So this was a child with primary congenital glaucoma who was referred to us when the baby was few weeks old, underwent combined trabeculotomy and trabeculectomy. And as a routine, we call them at 1 week later at 1 month for a EUA, examination under anesthesia. So when the baby came for the routine examination visit, we found under anesthesia, this was the kind of a picture. So there were infiltrates found in both the corneas. And later we came to know that the mother had infection in her genital passages. So possibly this child had this kind of a problem in the eye. And when underwent a cataract, the glaucoma surgery and used the steroids in the postoperative period, possibly this infection had come up. And the scraping showed candida, both the gram stain as well as on culture and on calcifer white staining. So the child was started on topical antifungals as well as oral antifungals with the help of a neonatologist. Left eye had, despite treatment, corneal perforation, and that was treated by a tissue adhesive and a bandage contact lens. And finally, both the corneas, the keratitis healed with scarring and vascularization. This child underwent, because now this baby was at 1 month, we noticed that, so that was 1 month after surgery. So when the child was about 3 months old, we had to perform a keratoplasty in both the eyes. And the left eye, as you see, had a perforation. So the lens was also adherent to the cornea. And during keratoplasty, the lens was also removed. So the right eye is phakic and the left eye is aphakic. And the posterior segment evaluation was very encouraging. So we could see that the pressures were very well controlled in the right eye. And the optic disc showed a 0.6 cupping and salt and pepper appearance because the child also had congenital rubella. And the left eye pressures were high, and hence the cornea was also quite hazy. And the disc cupping was about 0.8. And this child underwent a pars plana tube in the left eye, and you can see the cornea is crystal clear. And over a year after the procedure also, the pressures were very well maintained, and we could provide good visual outcome as well as good intraocular pressure control for this child. The reason why I started with this case is that this is at least not uncommon in our country and in the situations that we deal with for a tertiary eye care center, with the referrals that you get, which are quite significantly refractory glaucomas. So when we are dealing with pediatric glaucomas, I'm sure this is different across different countries. And we have to focus our attention in managing the type of glaucomas that we get in our places. So how do they present in our country? What are the surgical options that we have? How do we deal with them? And what are the outcomes like? And what special problems do we have in children? So the primary congenital glaucoma, like I said, is not very uncommon in India. It's a hereditary disease, and the variable incidences in different populations. In the Western population, we see them reported quite less, whereas in India, it is not very uncommon, and it is next only to the Slovakian gypsies and in Saudi Arabia. So we see it more commonly, the reason being a high degree of consanguineous marriages that are an accepted norm in southern part of India, and also because of the severe phenotype that we see in in this condition, where several of them require multiple interventions during the follow-up of their glaucomas. We have a huge variation in presentations. And when we looked at the profile of how do these childhood glaucomas present and what are the different types of glaucomas that we see, close to 56% of them were primary congenital glaucomas or developmental glaucomas, and 44% of them were secondary. So we know that secondary glaucomas are much more common in the developed countries, whereas primary glaucomas, primary congenital and developmental glaucomas are much more common in India. The primary surgery that we do, like in the Middle East, is also combined trabeculotomy and trabeculectomy. And we know that the outcomes are quite good in the early postoperative period, that is around 1 year or so, and close to 50% of them fail over a period of 6 to 8 years. And as time goes by, we know that like any other glaucoma procedure, there is scarring and there is failure. And like I said, we have a severe disease phenotype in our country where we see this kind of a clouding is not uncommon. That's one of the reasons why goniotomy is not a procedure that we prefer, because the corneas are so hazy that you will not be able to visualize the angle structures. And secondary glaucomas, like I said, because of these hazy corneas, several of them end up having a keratoplasty. And then even though the pressures were controlled prior to keratoplasty, they may end up having high pressures, and then we may need to repeat the glaucoma intervention in these eyes. So when we looked at our own data, over a period of 16 years, we saw that close to 1/4 of these patients who underwent primary trabeculotomy and trabeculectomy required repeat interventions. So close to 1/4 of them, or 25% of our primary glaucomas were refractory, and several of our secondary glaucomas are refractory, where sometimes the tube implantation could be the primary procedure that we may need to offer. So what do we do in refractory glaucomas? We have multiple options available, and glaucoma drainage devices are definitely something that has created a huge difference in managing these patients. Whichever procedure you choose, proper planning and appropriate selection of the type of implant and the way you do the procedure, I think significantly affects the outcome. We have two types of implants in our country. What we have is the valved Ahmed glaucoma valve and the ADI, which is similar to that of the prototype Bowelt implant, which is the oral lobe aqueous drainage device, which Dr. George has just shown beautiful videos of. We have the size in the ADI implant is only a single size that is available, which is 350 millimeters square, whether it is for an adult or a child. And in the AGVs, we do have the adult as well as the pediatric sizes. The pediatric one is much smaller. So the basic difference, I don't think we need to go into the details, but what we know is that in a non-valved implant, we ligate the tube, and that is why we have high IOP in the early postoperative period. To overcome that, we do slits and the fenestrations that helps us to control the intraocular pressure. What is it that we need to plan for an implant surgery when it comes to even for adults, it is the same, but when it comes to child, it is even more important, is to choose a right type of implant, choose the location of the implant as well as what incision you will make and where exactly. So every step has to be pre-planned. Length of the tube that you need to leave inside the eye, because you need to remember the child's eye is growing, and as the child's eye grows in size, the tube length could become relatively shorter. So we need to plan adequate length of the tube, and leaving a longer tube will lead to problems because children, again, the tube corneal touch is a major issue because they do rub the eyes irrespective of however careful the parents are. And also the location of tube placement. What I mean by location of tube placement is it in the anterior chamber, or do you want to place it in the sulcus or in the pars plana, depending on how the anterior segment is and the associated comorbidities in the eye. So this is a common question that is asked. How do you choose a particular type of implant, specifically whether it's a valved or a non-valved implant? I think we do agree that how soon do we need to get the intraocular pressures under control? How much of intraocular pressure control do you require? How often can they come back for review? Or sometimes we do have patients who come from a different state or a different country where they only have 2 weeks time with you. They want to have the procedure done and they will go back and they may not even come back for a follow-up. So these are very, very important in choosing a type of implant. Of course, the condition of the eye and associated ocular as well as systemic comorbidities are very, very important before you decide on which type of implant you choose. This is something that I specifically follow in children, which is the type of conjunctival flap. So, one second. Yeah, so the type of conjunctival flap is very, very important. I specifically tend to make a limbal-based conjunctival flap, meaning that the incision is about 6 to 7 millimeters behind the limbus, and the conjunctival incision is usually about 5 to 6 millimeters. Be it a valved implant or a non-valved implant, it doesn't matter. It helps to make the incision smaller. More importantly, for a non-valved implant, it helps you to identify and locate the muscles very, very easily. And it also, if you don't have the assistant who is able to assist you, like if you are a person who's handling individually, independently, also we will be able to manage the situation very easily. So that is one thing. And other important issue is that the conjunctival closure is done in a continuous fashion with a 80 vicryl suture that helps to make a very small incision and a single suture which is much more posterior. In children, this is specifically very, very helpful because you don't have to worry about the leak and things like that. Number one. Number two, since the suture is placed right posteriorly, the irritation related to suture is not at all there, and the child is comfortably able to open the eye the next morning when you see them. Choosing the location of the placement of implant is very, very important. Like I said, this is a child who has a staphyloма all over, and the only portion of the sclera that is at least relatively healthy is inferior and more so inferotemporal. So there is no point in, even though you say it's safer to put a superior implant because of the kind of limbus as well as the thinning that we see, it's better to avoid placing a superior implant. So inferior is ideal in this child. And that too, because of the stretching that is there and the need for a future keratoplasty, we decided to do a pars plana implant in this child. So choosing the type of surgery as well as choosing the placement of the implant is extremely important. And so this child underwent a keratoplasty, and after almost 4 years, the child was able to see this eye. And what was again very, very comfortable and comforting to see is that this child's optic discs were quite healthy. And if we treat this child well and take care of the amblyopia, the child will have useful vision in this eye. This is another child that very interesting, that left eye was thicical, right eye 1-year-old child, very high intraocular pressure. And this is the kind of cornea that was there. And a corneal surgeon said that since the pressures are very high, go ahead and do a tube implant. And if we bring down the pressure, then we should be able to do a keratoplasty and take care of this. So in the presence of a hazy cornea like this, like what Dr. Peter Chang also told, that we use an endoscopic view or an oblique illumination to be able to see the tube insertion into the anterior chamber. Once we do that, once with the pressures come down, we should be able to do a corneal procedure and take care of the visibility for the child. So this child is able to now move around and with the help of support, and it's very, very comfortable and happy to see this child become independent after 1 long year that the child was not able to see at all. So like I also told you that the eye rubbing is a serious problem in a child, and we give splints to the parents and tell them that they do not fold their arms and rub the eye. So this is something that we can take care of, but you can't be behind the child all the time. Like I said, 2 reasons why this can happen more commonly apart from the eye rubbing is also because we always think that leaving a little longer tube in the anterior chamber is safer because it can help when the eyeball grows so that you don't have a tube retraction in these children. Having said that, we can modify the way we insert this. So this was a picture that was taken of a case that I operated almost about 12, 13 years ago. But I wouldn't do this kind of a surgery today. If I have to leave the tube, like what George showed, we would make a sinuous track and leave a shorter tube in the anterior chamber. When I say shorter, maybe about 2 to 2.5 millimeters, not longer than that. And also the location of placement as well as the direction of the tube should be something that is not parallel that we used to parallel to the limbus that we used to do earlier, but perpendicular or so not perpendicular to the limbus, but parallel to the limbus, so that we will be able to leave a little longer tube, but much away from the visual axis. So the length of the tube, like I said, as the eyeball grows, the tube retracts, and in certain conditions, like you see the second picture here, there's a very short tube. You're able to visualize only after I press the limbus with the help of a bud. And when this will retract is again an issue that we have to be worried about. So little longer tube is important. But what we can do to help that is a parallel placement. So parallel to the limbus, even more parallel, you can try and make it so that even if the tube is a little longer, it is much away from the visual axis. This is one technique that I learned. I thought I should share this tip. This is from one of our fellow who was with us from Egypt. In fact, when he was assisting me for the surgery, he said when I was finding it very difficult for the tube to enter into the anterior chamber, and every time I tried to place it in the anterior chamber, it would go into the sulcus. So he said, why don't you twist the tube and try to place it so that when you try to make the bevel down, that is when you're inserting the tube, it actually goes in the direction and in the position that you want it to. So I'll just play this short video. You just reverse the tip of the tube and insert it. Because the sharp edge is now going in the upward direction, it will actually go into the anterior chamber. And once it reaches into the anterior chamber, you can just hold the tube and then try to make it straight. So you can make it bevel up. So this is something that I've actually learned to use in my children. So now, most often I don't have difficulty in trying to, because this is a phakic eye and you don't want to place the tube in the, and also the tube is already cut and I don't want to place it in the sulcus and also make it short for the eye. In certain conditions where you have both a corneal problem as well as a problem of high pressure, so generally I don't prefer to do combined surgeries. I either do the implant first and ask the corneal surgeons to take care of it later based on how high the pressures are. Or if you're not sure about what the visual potential of this eye is and the pressures are in the borderline range, I would tell them, please go ahead and do a corneal procedure. Let us see what is the visual, the posterior segment, how does it look like and how much can we rehabilitate. And if the pressures are on the higher side, we can always do a procedure to take care of the pressures at a later time point. This was once a child who was left unattended for almost 7-8 years. And when he came to us, the corneal diameter was something like 17 millimeters and a hazy cornea like this. So one eye we had, but the reason why we decided we will help is because the mother was very, very clear and says that he's independent, he's able to move around. And one eye, she said, is definitely something that he can see. So we would want you to help. So this child underwent a corneal procedure at a later time point. It did an implant for him. And fortunately, he is able to both control the pressures as well as continue to see with that eye. So staged approach is something that is very useful, especially in children based on the condition that are present. So these are a couple of publications that we have in implants in children, where we have actually compared the Ahmed glaucoma valve in the primary as well as secondary refractory glaucomas. And we found that the success probability were almost similar, where the marginally better in the primary congenital glaucoma, obviously for reasons that they do not have any other anterior segment or dysgenesis and difficulties or deformation. So the chances of problems of tube blockade and things like that are far less in those eyes. And otherwise, as time went by about 5 years, I think the success rates came down to 70% or 65%. And we know that as time goes by, depending on which type of indication it is, some of them do tend to fail, requiring additional interventions. This was a publication where we compared the Ahmed glaucoma valve with a non-valved, the ADI, and very encouraging results. And this was published a couple of years ago. With AGV, the success rates were close to 88% at first year, and which dropped to about 86% at 2 years. And with ADI, it was 91%. And until the last follow-up, which was, I think, about 2.5 years, it was about 81%. What I wanted to highlight was with ADI, The intraocular pressure control was far better compared to AGV as is expected, and the number of medications that the kids required in the follow-up was also much lesser in the ADI group compared to AGV. Whenever we say this, the success was better with the non-valid implants, the common question that is asked is, what about complications? So we did look at complications, both the early as well as late complications, and we divide them apart from the time of presentation as non-sight threatening and sight threatening depending on the severity. And we found that the non-sight threatening complications were a little higher in the ADI group compared to the AGV group, but several of them did not require an intervention. So when we looked at those that required an intervention, they were almost similar. And the serious complications were almost similar in both the groups. And also the complications that we said, like tube erosions and extrusions, is something that we need to be extremely careful about. Fortunately, these were some of the pictures that were taken. Majority of them were the referred patients that we were taking care of. Fortunately for us, none of these children had tube erosion or an exposure or an implant exposure in our series. The other problems that we worry about is their intraocular, because it's kids and we are not able to record the pressures every time they come to the clinic. What we do in the clinic is we do check the pressures with eye care, and we have also published our results that if the eye care intraocular pressures are 19 or less, we know that this correlates very well with the GAT or the Perkins, so we do not EUA them. But if these pressures are higher than that, then we definitely need to, depending on the follow-up, we need to take them up either under sedation or anesthesia to check what the pressures are. High intraocular pressures is something that we have to worry about early in the post-op period for a non-valid implant. And most often the fenestrations are able to take care of. But what I have seen in my experience is that with fenestrations, first 3 to 4 weeks, they are okay. By the next 1 or 2 weeks before the ligature opens up, the pressure starts going up. So we need to keep following them up very closely. But with a valved implant, close to 40% of our children had hypertensive phase with very, very thick blebs, and we have to deal with these high pressures. And very rarely we also see hypertensive phase in non-valid implants. So when in fact, I did not find much literature about this when I was writing my paper, but I realized that in our cases, close to 16.5%, close to 17% of them had hypertensive phase even with ADI, but that was very short-lived, and the pressures were not as high as what you would see in a valve implant. Hypotony is a serious complication. This is something that we have to worry about. And for me, what I have noticed is that hypotony that happens at the time of ligature opening is there, that you expect and you see, but in kids especially, I have seen delayed hypotony that happens beyond 3 to 4 months. So 2 reasons why I specifically see this is because when we tend to taper down the steroids very quickly, this can happen. So we need to continue after the ligature opens up. We need to, so until then, what we do is that we use steroids up 4 or 3 times, depending on the inflammation that you see in the eye, until the ligature opens up. And by the time, maybe a week around that, we tend to increase the steroids as well as increase the dosage of cycloplegics to almost 1 to 2 hourly. And then now I have learned from my own mistakes that I tend to taper them 2 weekly and not very, very fast. And if the eye is showing the pressures are in the little lower side, or you have increased choroidal thickness that we notice on a B-scan, then I would tend to continue the steroids in a higher dose, for a topical steroids in a higher dose for a little longer time. And with that, we are able to overcome this delayed hypotony, especially in children. I'm not seeing this in adults. And another problem that we see in children when they have hypotony, either because of the long-term use of steroids or hypotony itself, because of the aqueous changes that happen in the eye, they tend to develop cataracts. And that is not something that we want in our patients. How can we prevent hypotony? Like what George has shown, I tend to generally use 24 gauge needle entry, both for children as well as for adults. In fact, for a pars plana tube entry in a child, I use a 26 gauge needle entry. That itself actually snugly fits because the sclera stretches. That's not a problem at all. So I've rarely had a difficulty in inserting a tube, but I generally would not want to use a 23 or a 22 gauge. With this early postoperative hypotony, you can prevent to a significant level. And of course, postoperative follow-up is very, very important to prevent hypotony by understanding what changes are happening in an individual patient. One investigation, if somebody asks me, that is mandatory for me, especially when I'm managing children with implants, is ultrasound B-scan. This is one instrument that has helped me to decrease the number of EUAs as well as to decrease the sleepless nights, both for the children as well as us. by doing an EUA as and when needed. In fact, I do it at every single visit that they come. It's very easy. It just takes you a couple of minutes, but it gives you a lot of information. The first picture is of the child where the implant was placed, and there was absolutely no filtration that was happening behind. The second picture, it was around the time, maybe about 4th to 5th week, when the ligature is not complete. So ligature is not like it suddenly opens up. It slowly becomes looser, and then one fine day it completely opens up. So there is some fluid that is entering before the ligature has completely opened up. And this is a picture. The third one is a picture where the ligature is opened up. You see there's a lot of fluid around the plate, and you also see there is increased choroidal thickening, and there is some inflammation in the vitreous cavity. This is a child, it's a different child actually, where you not only see excess fluid, you also see a choroidal detachment as well as thickening of the choroid. So it helps you to understand what is the stage like. Is the fluid filtering or not? Has the ligature opened up? Because some of these children just don't allow you, and if you try to forcefully try to open their eyes, they tend to squeeze more. It will only be more harmful. So ultrasound is something that can help you significantly to understand what is happening, and of course in the follow-up to understand what the resolution is like. So these are serial images that I generally tend to do for my kids, and very, very helpful. So just to summarize, refractory childhood glaucomas are definitely a challenge, and especially with children, because their eyes are very difficult to deal with, plus the post-operative follow-up and managing the problems that we have. Choosing an appropriate type of surgery as well as appropriate type of implant and modifying the surgery as per the need of the eye is extremely helpful in avoiding serious complications. And like I said, I don't have to really emphasize the role of tubes in these children. Several of these eyes that I showed you would have actually gone blind if not for the implant procedure. Earlier, we used to do a trab and then a repeat trab and maybe another needling, and then you would shift to a limited cyclodiode. Any of these procedures were more destructive. So today, I think with implants, we're able to salvage several of these patients and to follow them up quite well. And we have to remember that these eyes, you're going and putting an extraneous implant, which is so huge. It has a large plate, and there are several areas inside the eye. The tube can cause problems. In the subconjunctival space, it can cause problems. So we have to be aware of the implant-related complications apart from the high IOP and the low IOP that we have to deal with. So we have to follow them up very, very carefully. And of course, meticulous long follow-up is something that is definitely necessary for these kids. Thank you for your attention.
Thank you very much, Dr. Sirisha, for this nice presentation. So just I want to a question for you. In aphakic glaucoma, where a chance of suprachoroidal hemorrhage is high. Actually, I have a bad experience with that. I have operated 2 or 3 cases of aphakic glaucoma. I did trap and they ending by suprachoroidal hemorrhage. So do you prefer?
Your voice is breaking, Mohammed.
Tube surgery.
Yeah, I was not able to hear your question. Can you please repeat, because your voice was breaking?
Can hear me?
Dr. Mohammed, we can't hear you. Dr. Mohammed, you have some problem in your sound. We can't hear you.
Now, you can hear me now, Dr. Ahmed?
Okay, it's better now.
Yeah, just I was asking about aphakic glaucoma, where a chance of suprachoroidal hemorrhage is high.
Yeah.
Do you prefer to do tube surgery as a primary procedure, or you prefer to do trap then tube surgery? Because as I told you, I have a bad experience with aphakic glaucoma. I've operated the 3 cases with trap ending with suprachoroidal hemorrhage. So what's your opinion?
Yeah, so I think I agree with you that a large aphakic eye is something that I'm really scared of operating. So if you ask me one case that I would really be skeptical about, operating unless I am really pushed to, is large aphakic eye. So there are 2 different types of aphakic eyes that we deal with. Post-cataract surgery aphakia, where the eyes are not very large, are still okay. In an eye that is vitrectomized and that is aphakic and which is highly myopic are the eyes that are more dangerous and who have had a high pressures for a very long time. So prolonged high intraocular pressure and a sudden decompression is something that we will end up having problems with. Whether you do a trab, whether you do a limited trab with meaning a trab with tight releasables, or you do a valved implant or a non-valved implant, any of these can cause problems for you. In fact, I've had situations where I put a valved implant and gone and ligated the tube because you're so scared that you just don't want the sudden decompression to happen. So having said that, a couple of things that can help us is to maintain the anterior chamber while doing the procedure. Make sure that at any point in time intraoperatively, you do not encounter hypotony. So this happens when we place the tube in the eye or when we do a trab and then suddenly there is a decompression. By the time you go and we do pre-place sutures, but still by the time you go and suture the flap, you may have a sudden hypotony. So placing an anterior chamber maintainer, or if it is possible, if it is a small, means like the pupil is very well and you want to leave viscoelastic in the anterior chamber, you can do that. But placing an anterior chamber maintainer is something that is significantly helpful to make sure that you don't have an intraoperative hypotony. Even in the post-operative period, so non-valved implants, since you are trying to ligate the tube, there is not much of a sudden decompression. But having said that, when the tube ligature opens up by 6th or 7th week, then you can have a problem as well. Another thing that I have, at least in what I do, is that post-operatively make sure that the patient, so peritubular leakage is another very, very important thing that you need to take care of. So if it is with a tube, with a trab, releasables and tight sutures. So normally for a child, when I do a trab, I only put a single suture. I don't put, or with a combined trab and trab as well, I only put a single apical suture. I don't put additional sutures. But this is one condition where I would place extra sutures and titrate with the filtration that is happening on the table. And on table, I don't know whether you call it, I am paranoid about it or what, but on table, I give a dose of dexamethasone. I asked my anesthetist to give a dose of dexamethasone. And day one post-operatively, I always, so day one, if you see the pressures are 7 and 8, this is not something that I expect because I did leave the eye a little tighter. If 7 and 8 on day one, I definitely will call them 2 days later, because day one, they may be okay. When they come back 1 week, you will see a suprachoroidal. You don't want that to happen. Second or third day, you want to see whether there is more hypotony that is happening. And if that is the case, then you would want to watch them more carefully, or you want to intervene. You have to do something about it so that you will prevent this. In case they develop a suprachoroidal, then how do you manage is something that we have to worry about. But one of the things that has recently, we've had a couple of patients. One child specifically, I remember, the retinal surgeons did a fantastic job. So having a suprachoroidal and then being able to salvage the eye is something that is not easy, but there is a particular technique that they do where they use apart from the drainage that they do, they fill the eye not with the oil, but they use a PFCL to fill the eye for a week or 10 days. And after that, they exchange it if necessary with oil. Otherwise, they just remove the PFCL. That will actually provide enough tamponade and it will prevent rebleed in these eyes. So these are a couple of things that I can share.
Thank you very much, Dr. Sureisha. Dr. Peter, with us?
Yes, I am here. Yeah, so Dr. Sureisha, wonderful presentation. My question is...
I just want to ask you this.
No, actually, I want to get Dr. Sureisha's impression on how to manage a tube shunt implant that's being placed into an eye with Sturge-Weber glaucoma. I find these eyes to be extra challenging because the pressure is either too high, or even with just very modest pressure reduction, you end up getting choroidal effusion in a flat chamber. Do you have any tips or tricks that you find useful?
Yeah, so in the recent past, so Sturge-Webers, I think we should divide them into two different groups. The Sturge-Webers that presents very early. So if you ask me what is early, a year or less, who present with glaucomas. So for us, the first surgery is not a tube shunt. We do the conventional trabeculotomy or trabeculectomy and trabeculectomy, because there the problem is the angle dysgenesis and it is not the raised episcleral venous pressure that is causing an issue. And most often they work very well. So these children generally don't tend to have very serious post-operative problems. Some of them have a limited suprachoroidal and they just resolve in no time. Only additional thing that we do for them is put them on oral or syrup prednisolone in the post-operative period, at least for 2 to 3 weeks. And then that helps to resolve the blood very fast. And of course, the inflammation, because inflammation again can induce choroidal detachment and things like that. But in the later age group, so usually where I find problem is with the children who are 10 to 12, 13, that age group. So in the early to mid-teens are the ones that have a lot of difficulty. And in the recent times, I think in the last year, there was a publication from India, from the PGI group, where Dr. Sushmita has shown that use of oral propranolol is significantly helpful. That is something that I routinely do for my patients now. And I think now I can comfortably operate this. Not that they don't have a problem, but you know that the effusion is an expected thing in these eyes. However you do, whichever type of surgery you do, intraoperatively, you never have a hypotony, you manage with viscoelastic, you manage with anterior chamber maintainer, whatever. But in the postoperative period, you are doing a surgery to decrease the intraocular pressure. When the intraocular pressure decreases, you will definitely have these issues. So what we do is that we start them, instead nowadays what I do is I start them 1 week prior. So 2 milligram per kg body weight is the maximum dose that we can go up to. Initially, our physicians were very skeptical. They would say that, okay, start it and then progressively increase, but I don't think that helps. In my experience, you do it maybe 1 or 2 days pre-op. When you do it, you cannot worry about hypotension in these children. Generally tolerate it so well that they have no difficulty. But this is something that I do, continue it for 6 weeks. And then based on how the response is, taper it 2 weekly and stop it. So this is one modification for my Sturge-Weber's that I have done, whether it is an implant or a trab or whatever I'm doing in these older children. But very young children, I generally don't worry so much about it. In fact, we don't even do prophylactic sclerotomies for them. They do reasonably well.
Muhammad, Dr. Nawaf?
Yes.
Dr. Muhammad, you are still have the problem in your sound. We can't hear you. Dr. Nawaf, if you wanted to moderate now, you can.
Yes, thanks for the very nice presentation. So now we can move to the next talk with Dr. Prof. Wissam. We'll talk about to trab or to tube, tips to make it the right call. You can start, Dr. Prof. Wissam.
Thank you very much. Can you see my slides?
Yes,
yes, we can now.
It's clear.
All right. Thank you very much, Dr. Muhammad and Dr. Nawaf, for the kind invitation. I'm truly privileged and honored to be among this international panel of glaucoma surgeons. In my presentation, I'll be talking about the pros and cons of filtration surgery versus tube surgery. I'll be also elaborating on the 2 major randomized clinical trials that address the subject. And finally, I'll summarize some factors and variables that might help you to take the right decision on which way to go. Those are my disclosures. Nothing is truly pertinent to this presentation. Now, glaucoma surgery is indicated whenever you fail to control the intraocular pressure with the medical treatment and the appropriate laser treatment. And everybody is talking about nowadays about MIGS because of their excellent safety profile, but they have not replaced the traditional glaucoma surgeries, Untitled Trabeculectomy and tube surgery. And it's pretty much a trade-off. Added efficacy to the procedures that we know so far is more or less on the expense of the safety. And I'll be elaborating on this shortly. Why MIGS never replaced the traditional procedures so far? Because we cannot achieve low teens or single digits IOP levels with MIGS, and those levels are sometimes needed in certain patients with advanced disease. Oh, which one is better, trab versus tube? Obviously, there is no simple answer to this question. In the American Glaucoma Society surveys, trabeculectomy has remained the most popular procedure as an initial approach to patients with open-angle glaucoma, but there has been a trend of a growing number of glaucoma surgeons that prefer to use tube shunts even as an initial procedure. And that's pretty much a change in the practice pattern and the practice paradigm. Is there a consensus? Obviously, there is no clear consensus among glaucoma specialists regarding the preferred surgical approach in managing patients who require low teens level of intraocular pressure. Now, in order to understand this better, let's go for the first major randomized clinical trial, which is the tube versus trab study. It's a multi-center randomized clinical trial that studied 212 patients that were randomized to the tube group and the trab group, pretty much in equal proportions. And those patients had prior cataract and or glaucoma filtration surgery with uncontrolled intraocular pressure ranging from 18 to 40 on maximum tolerated medical treatment. They were again randomized into two clinical groups. The first had trab with mitomycin versus the second group that had 350 barbell tube. And outcome measures included intraocular pressure, visual acuity, visual field complications, glaucoma meds, and treatment failure. The one-year results of the TVT study showed that pretty much the intraocular pressure reduction was almost the same. There was no clinical significant difference between the two groups. In the tube group, the average intraocular pressure was around 12.4, while in the trabeculectomy group it was like 12.7, and there was no statistical difference between the two groups. However, the number of post-operative glaucoma medications were significantly lower in the trabeculectomy group in comparison to the tube group. On the other end of the scale, failure, that was defined either intraocular pressure above 21 or not reduced by 20% below baseline on 2 consecutive visits, also was defined as hypotony less than 5 millimeter mercury, reoperation for glaucoma, or loss of light perception. Those failures were noticed in around only 4% of the tube group, while it was as high as 13.5% in the trab tube. This is at 1 year follow-up. So, in summary of this randomized clinical trial, we can tell that both achieved sustained intraocular pressure reduction in low teens over the period of follow-up. Reoperation rate was significantly higher in the trab group, almost 29% required reoperation, while only 9% of the tube group required reoperation. And complications were higher in the trab group early on. Most of them were self-limiting and transient. Later complications were equal in both groups. So, what did we learn from the TVT study? No procedure is superior to the other in terms of intraocular pressure reduction, in terms of late postoperative complications. Probably trab group had the edge over the tube group by the number of postoperative medications on the short follow-up time. Technically, trab requires the surgeons to tailor many variables, while the tube is more or less a standardized procedure. Also, this study supported expanding the use of tube shunts, because in the classical scenarios, we were thinking of a tube shunt as only for refractory cases. This is not true anymore. A lot of people are shifting in their practice paradigms and patterns to consider it as an initial procedure. And it goes without saying that trab requires more vigilant post-operative care. And that's probably one of the very, very important crucial points to decide on which way to go, whether the follow-up is limited or not from the surgeon point of view as well as the patient point of view. And finally, to say that the surgical options following the tube surgery are limited. Either you put a second groove or you consider cyclophotocoagulation. Also from that study, we were able to tell that trabeculectomy has other two advantages over tube. It can achieve single-digit levels, which is sometimes required in certain patients with advanced disease. In contrast, intraocular pressure following tubes usually settles somewhere in the mid to high teens. And the second advantage that it reduces the need for post-operative topical medications more than the tube group does. The second major randomized clinical trial is the primary tube versus trab study. And this procedure was done performed on eyes that have not undergone any previous incisional surgery. So more or less, we're talking about virgin eyes in terms of incisional glaucoma surgeries. Again, they were randomized into two groups, the 350 Barvelt group and the trab mitomycin group. And the participants were included with pretty much the same inclusion criteria that was in the first TVT study, except that they had no previous incisional surgery. The one-year results of this trial showed that trab group had lower intraocular pressure with fewer glaucoma medications. And on the other hand, showed that the frequency of serious complication producing vision loss or requiring reoperation was lower in the tube group. So more or less, I can say that over 1 year of follow-up, the trab was more effective, but less safe. Those are the 3 years results, and we are waiting for the 5-year results to be completed by next year. The 3 years results showed that the intraocular pressure was greater in terms of reduction in trabeculectomy group in comparison to the tube group. The rate of surgical failure was even higher in the tube group at 1 year, but equalized thereafter. Medical therapy that's required post-operatively was more in the tube group. And the other variables, including complications, post-operative intervention, visual acuity, and the rate of cataract formation or progression was pretty much the same. So as I said in the beginning of this presentation, it is some sort of a trade-off. Your choice of a tube or trabeculectomy or MEGS may ultimately come down to the safety versus efficacy profile. And there seems to be an inevitable trade-off between safety and efficacy in glaucoma surgery, at least with the procedures that we know so far. Hopefully in the future, we'll see a procedure that's very effective to bring the pressure to low teens and at the same time very safe. So in conclusion of this presentation, there are certain variables that you need to think of before going for the filtration site surgery approach or the tube surgery option. One of them is really an important factor is surgeon skills and experience. If you don't have the luxury to refer the patient to a colleague, you need to do whatever you are comfortable with. Since most of the literature is showing equivocal, almost equal outcomes in both the groups, so the surgeon skills will play the major role in this case. So whatever you are comfortable with, you have to take that in consideration as long as you have to operate on the patient and cannot refer the patient for another procedure. This is, I think, is the single most important factor is the follow-up. If the follow-up is limited from the surgeon point of view or the patient point of view, it's better and safer to go for the tube option rather than the trab option, because as we said, trabs need very, very careful post-operative care. I'll put myself an example. I operate and do glaucoma surgeries in 3 countries. One of them is my country, Jordan, and I do glaucoma surgeries in 2 other countries overseas. Whenever I operate overseas, I do pretty much always tubes. And I rarely do trabs. Because I believe whenever you're done with the tube, the story is pretty much over. All what's left is to pray that your tube will continue to flow and to function. That's pretty much it. But when you do a trab, that's only the beginning of the story. You will need to do many interventions post-op, and you have to be around, you and the patient. You might need to ablate the AC, you might need to laser the sutures, you might need to needle, and those necessitate the presence of dedication and the dedication for meticulous follow-up. So again, this is probably the single most important factor to determine if you are available for follow-up as a surgeon and the patient can easily come for follow-up visits, you can consider both options. If not, I think tube option is the safer one. Availability of tube shots. Maybe this is not an issue in developed countries, but it is a major issue in developing countries. I am aware of some countries where tube shunts are not there at all. So you're lifted with only one option, and this is why you need to improve skills in this available option. And there are ocular factors that also determine which way to go. Like patients with expected high-risk failure of filtration surgeries, like patients with neovascular glaucoma, uveitic glaucoma, eye syndrome, epithelial downgrowth, aphakia, previously failed traps, and the list is even longer, patients with a scarred conj, with the chronically inflamed conj, etc. Those patients, they will do better with the tube group in comparison to the trap group. I will add two other points that probably not addressed clearly in the literature, but at least this is what I found, and this is what I feel comfortable doing. In patients with advanced cupping, where the patient do have significant optic nerve damage, and I mean by that above 0.9 cup to disc ratio, or in patients with single eye patient, I usually feel it's safer to go for a more controlled intraocular pressure. So I prefer to use the valved glaucoma shunts rather than the non-valved or the filtration surgery. So that's pretty much it. And the take-home message of my presentation is that one size does not fit all. You have to balance all the factors related to the patient himself, to the surgeon himself, to the setup, to decide what's the right decision to go that will end up with a favorable diagnosis, with the favorable management. Thank you very much.
Thank you very much, Dr. Wissam. I think now you can hear me well.
Yes, I can.
Yeah. Actually, it's very nice presentation. This question to trap or to tube is coming to us in special cases as a primary procedure in cases like neovascular glaucoma and ICE. So do you prefer in cases like that, neovascular glaucoma and iridocorneal endothelial syndrome, do you prefer to do a tube as a primary procedure, or you do trap then tube?
Yes. Well, patients where you expect that the expected success rate of filtration surgery is low, I do prefer to go for an initial tube, like the ones you mentioned, neovascular glaucoma, uveitic glaucoma, eye syndrome, epithelial downgrowth, aphakia, severely scarred conj, or chronically inflamed conj. Those I prefer to go for a primary tube because I believe that the success rate with the filtration surgery, even if adjuncted with antimetabolites, is still lower than the tube surgery. Now the paradigm is shifting to even doing an initial valve procedure for primary straightforward open angle glaucoma. And that was the second randomized clinical trial that we were talking about. So this is probably a controversial issue, and a lot of debate will be on it, whether you give the patient the chance to go for filtration surgery first, so you don't burn further bridges in the future to go for a valve in the future, or you go for an initial valve and you get some sleep and some rest. That's again a debatable issue. But as you said, for patients with high risk filtration surgery, I would definitely go for an initial valve.
Okay, good. Just can we ask other panelists if they are doing, I mean, tube surgery as a primary procedure in cases like that? Dr. Surisha, can you hear me?
So tubes as primary procedures only in secondary glaucomas. In primary glaucomas, we are not doing it. And several secondary glaucomas, most often if the anterior segment is quite distorted or if the conjunctiva is not in a position where you can do a trap. Even in neovascular glaucomas, our primary option is to do a trabeculectomy with mitomycin C. So tubes are not generally the primary procedure for us.
Okay. And so I mean, mainly you are doing TRAB and then you go ahead with tube surgery. If needed.
But if suppose this is a post DSEC eye, which is quite distorted anterior segment, or a post vitreoretinal surgery where the conjunctiva is not good in scarred and things like that, in those situations, of course, tube is first preference.
And Dr. George?
Yeah. So
same question to you.
Yeah. So in spite of several studies like the TVT and the PTVT, which supports growing evidence for primary tubes, I think the take-home message should be indications for tubes still remain failed trabeculectomy or situations where trabeculectomy are deemed to fail. So deemed to fail, there were the two questions like that was asked today. Glaucoma in aphakia, Sturge-Weber, these are all conditions where the risk of choroidal, suprachoroidal hemorrhage is quite high with trabeculectomy. Then many secondary glaucomas, like developmental glaucomas like aniridia, iridocorneal endothelial syndrome. Again, neovascular glaucoma, we would prefer to put in a primary tube. But the question of, I agree with Dr. Vaisam that you need much less of shepherding in the postoperative period for tubes, but I still would differ from his views that distance should not be an issue in the take-home message. I would slightly differ and say that for a primary glaucoma, I would still prefer to do a trap and keep it as the second resort. Probably earlier we used to even try a repeat trabeculectomy with mitomycin, with a higher dose mitomycin, but nowadays after a single failed filter, we go in for a tube implant. So any previous intraocular surgery, like a previous vitreoretinal surgery, previous penetrating keratoplasty, these are all good candidates for a primary tube, but I would still differ if it's an untouched conjunctiva post phacoemulsification, clear corneal phacoemulsification that needs a surgery for glaucoma. I would still prefer to do a trabeculectomy with mitomycin as my first surgery of choice.
If I can comment, Dr. Muhammad, I would agree totally with Dr. George. The idea in glaucoma that we are talking about a chronic, lifelong disease. So you are always trying to save as much as possible conj for future intervention. Don't burn bridges going down the hill with the glaucoma procedures. So whenever you have the chance to go for filtration surgery, it's always better to start with. But whenever you think that the chance of success of filtration surgery is very low, I think you will be losing more nerve, more time, and you will be scanning the conj even more if you don't go for an initial part.
Okay, doctor. One more questions in the cases like a neovascular glaucoma, also an ICE, where there is a pass about 360-degree peripheral anterior synechia. How difficulty to put the tube you find it? And
well, it depends how crowded the anterior chamber.
Anterior chamber or differently?
Yeah, it depends how crowded the anterior chamber is. So if the anterior chamber is crowded and really shallow, I'll have other two options, whether they go for the sulcus if the patient is pseudophakic, or to go for pars plana vitrectomy if I need to go for that option. Again, in those patients, usually they have lens opacity. So I prefer to go for a dual procedure. I do phacoemulsification, then I insert the tube in the sulcus.
Thank you very much, Dr. Wissam.
I would like to share an observation, and I think that's the strength of having such an international panel. A large part of my practice involved young men and women from the Caribbean who are of African descent. And they get glaucoma quite early on in their 30s, 40s, and 50s. And early in my practice, I did very aggressive trabeculectomies with mitomycin anywhere between 5 to 7 minutes. And I can count on one hand the number of traps actually survive more than a year. I think their healing process is different than those in other parts of the world. So what I started doing for this group of patients was primary, sometimes juvenile open-angle glaucoma or primary open-angle glaucoma. If the visual field defect is mild, I would do angle surgery. I do a GAT. That's my favorite procedure for that group. However, if they had moderate to severe glaucoma, I will actually do a primary tube in the infranasal quadrant. the thought is right now, when they're young and quite robust, their conjunctiva behaves in such a way where trabeculectomy is not likely to survive. But if I were to put in the inferior tube shunt, buy them a couple of years, get them off of as many glaucoma medications as possible, then when I do a trabeculectomy in the future, that trabeculectomy is more likely to survive. And I still have the option, if the second procedure, the trabeculectomy, fails, of putting in a superior tube shunt. So that's 3 procedures total that I will get to do in that particular patient.
Thank you very much. Any comment from Dr. Yasmin about this?
Yeah, well, I share the same experience with Dr. Shang because I do operate on patients from Upper Egypt. Sometimes they're darker and they have a more aggressive tendency to scar. So just the same experience happened. So I started doing traps for those and they failed remarkably. So now I'm shifting to angle surgery, either GAT or ab-external trabeculotomy, even for patients with previously failed traps where I would have escalated into doing tube surgery. I would go back and address the angle. Even if they go back to treatment, a 1 drop would be better than having to go through a more invasive procedure. But my question to Dr. Shang is, sorry. Yeah. Sorry, it's slowing down the internet.
Yasmin, I think you have some problem.
Yeah, it's fine. Yeah, it's okay, no
Please
problem.
repeat the question, would you please? Because we can't hear the question.
Yeah, about the infranasal placement of tubes. So you prefer to place the first tube in the infranasal quadrant rather than the supratemporal?
Correct. Yeah, my thoughts were to spare as much of the superior conjunctiva as possible. Because when these young/middle-aged patients becomes elderly, then they have pristine conjunctiva superiorly where I can do a trabeculectomy if I choose to. So my primary tube in young African descent patient who form exuberant scar tissue is actually an infranasal barbell implant.
Right, interesting. But for the adult patients, say with primary open angle glaucoma, you would go for a supratemporal approach for those?
If they're quite young, and I think they're going to need multiple procedure, I still use the inferior quadrant first. And also, my other career is as a strabismologist, and postoperative acquired diplopia is a large part of my practice because my institution is where the TBT is from, and everybody gets a tube there. Infranasal tubes have a lower risk of acquired diplopia compared to supratemporal tubes. Now, in an elderly person who perhaps no longer has fusional abilities, who do not have equal vision, diplopia is not as big an issue compared to a 40-year-old who's still driving to and from work. And so I find inferior tube has that additional benefit of decreasing the risk of acquired binocular disturbance compared to a superior tube. So that's an unconventional way of approaching it, but in my hands, it seems to make sense for my particular patient group.
Yeah, that's very interesting. Thank you.
Thank you very much. Now I think we can just move to Dr. Mina. Dr. Mina, can you hear me? Dr. Ahmed, can you hear me?
Yes, we can, Dr. Muhammad.
Dr. Mina is there?
I don't know Dr. Mina is. Dr. Mina, yes, she is here.
The host has stopped me in sharing the screen.
You can share now, Dr. Amina. Maybe
Okay.
maybe you leave and rejoin or something. I don't know.
Is it visible?
Yes,
Yes,
now we can
yes.
see your presentation. Just
Yeah, I'll make it in.
slideshow.
Yeah, thank you very much, Mohammed, for this wonderful opportunity. I'm learning a lot from this all eminent speakers. So I've just little bit modified. It's not only Ahmed Lokma valve. I'll little bit talk about other non-valved implants as well. So already we have discussed in detail about the tube versus trabeculectomy study, but many a time conventional anterior chamber placement of the tube can result in a lot of complications like tube corneal touch, the corneal endothelial issues, flat anterior chamber, and certain eyes like this, as we were discussing, some of these eyes with extensive peripheral anterior synechiae and shallow AC, anterior chamber placement may not be really possible. So as an alternative to this problem, pars plana insertion was introduced in 1991. So what are the situations where we need to place the tube in the pars plana? Many of these secondary glaucomas like Axenfeld-Rieger syndrome, where there is an extensive pars and a disorganized anterior chamber. Many a time secondary glaucoma with severely compromised endothelial function. Of course, post-penetrating keratoplasty, many a time just to save the graft, we prefer to put it in the pars plana. And we had a great discussion in many times. Neovascular glaucoma, especially when it is a vitrectomized eyes with scarred conjunctiva, multiple surgeries being done for retina or otherwise, probably we prefer a pars plana insertion. So this is one study where they have done almost 45% of the cases. Quinn et al. They found that in primary open angle glaucoma, they had done this tube placement, but in their study, only 8% they had neovascular glaucoma. Now, what is a requisite? I have not put it as a prerequisite because it can be either a prior complete pars plana vitrectomy or it can be done along with the Ahmed glaucoma valve or Bellwelt or ADI. So it need not be always a prior vitrectomized eye. I'll just tell you about what are the devices which we can use in this pars plana insertion. So the first one is a PC7 device, which is an Ahmed glaucoma valve, wherein there is a pars plana clip. So this clip helps in avoiding the kinking of the tube. And this is a model which is FP7. That's a normal Ahmed glaucoma valve, which we generally use. And you have the same way for adult also, PC8 as well as for pediatric FP8 valves. And this is the Bearwelt implant with an Hoffman's elbow, something similar to pars plana clip. And this is of course ADI. So I'll just go through some of the case scenarios. This is a case of a 38-year-old female who had therapeutic keratoplasty and followed by a penetrating keratoplasty when she developed a secondary glaucoma. So here we have already implanted secured the implant onto the sclera, and after that my retinal colleague is proceeding with a pars plana vitrectomy. So this is a 23 gauge vitrectomy which is doing. So this is very important to use an intravitreal triamcinolone so that we'll know that there is a complete vitrectomy done. So that helps in any kind of a tube blockage which can happen. I use the same port which is used by my retinal colleague to put in the tube. Usually pars plana, we make it a little longer tube, around 3.5 to 4 millimeter. You can put it into the pars plana. Till the tube is inserted into the pars plana, we generally keep the irrigation on. Once we insert into the pars plana, then you can take off the irrigation, and then your steps are similar. You can anchor the tube onto the sclera, followed by a patch graft and then a conjunctival suturing. This is a second case, similar case. It was again a fungal keratitis wherein my cornea colleagues had done a TKP followed by a PKP with intraocular lens. And when she developed a refractory glaucoma, we decided to do an implant surgery. Now here again, it's an Ahmed glaucoma valve wherein I've already anchored it to the sclera. Now, I am not very comfortable with George's technique of tube trap. So I use a small flap and then insert the tube. So this, you can see that it is a pseudophakic eye. So I decided to put the tube into the sulcus. This was already vitrectomized eye. I mean, anterior vitrectomy was done. So I didn't go for a repeat vitrectomy again. So once we get a flap, then we put the tube onto the into the sulcus. Adequate length of the tube is placed into the sulcus. So when there is a sulcus placement, again it is much away from the corneal endothelium, and the graft failure chances are much lesser. So I used a 24 gauge needle generally to make the entry. So once we make the entry, the tube is inserted onto the sulcus. Then I just put a little bit of viscoelastic at the track just to an easy insertion of the tube. And this is a tube holder which I use to insert the tube into the ciliary sulcus. Then once that is done, it is followed by the routine procedure. Again, you can suture this flap, and then sometimes I use a flap over this also, and then a conjunctival closure is done. So this is another situation. This was a boy who was 28-year-old male who had a penetrating injury followed by a lid repair and pars plana vitrectomy with belt buckle and silicone oil insertion was done, and then followed by silicone oil removal was also done, wherein he developed secondary glaucoma, and esophageal was placed after a few months, and then Ahmed glaucoma valve implant was done in the AC. But unfortunately, after around 2.5 to 3 years, he had a tube corneal touch. So if you see carefully, this is a tube corneal touch which is there, and this is the original scar which when he had the injury. So we noticed that there was a severe endothelial dysfunction which was happening, and so we decided to reposition the tube into the pars plana. Mohammed, am I audible?
Yes, Dr. Meena, you are audible.
I'm not able to move my slides.
Dr. Ahmed, do you have any idea?
Okay, fine. I think.
Yes. Okay.
So this is sorry for the poor quality of the video. This is a pretty old case. So I have removed if you can see here, I have removed the tube from the anterior chamber. But there were a lot of fibrosis because of the multiple surgeries, and because this exit of the tube had made a little bit of corneal hole, so we had to suture it back. Now once we remove this tube, it is almost the same length which I have put into the since it is already a vitrectomized type, we didn't have to do a vitrectomy again. So the same tube is implanted into the pars plana. So just checking for the patency and reassuring the length of the tube, and then the same tube is inserted into the pars plana. Then again, I used a patch graft, and then the conjunctiva was sutured. So you can see here his cornea became much more clearer, and this is the after almost 1.5 to 2 years photograph, wherein the cornea is looking much better, and the patient is enjoying pretty good vision as well. Now, what are the complications you can face with this? Immediate post-operative complications, as we were discussing, you can have choroidal effusion, delayed suprachoroidal hemorrhage, and I'm sure Dr. Yasmin will be dealing that in detail. So I don't want to get into the treatment modality right now. And one of the common things which we can encounter is a blockage of the tube with the remaining cup of vitreous. This was an interesting case report which was there published in Journal of Glaucoma, wherein it was an ab interno management of a blocked valve. So what they did was they used a 3-port planar vitrectomy was performed to inspect how the ostium of the valve looks like, and then they didn't disturb externally at all, or any conjunctival dissection was not performed, they used a 27 gauge cannula, which was introduced through a vitrector site, and that was used to cannulate the tube. So you can do an ab interno management instead of again disturbing the conjunctiva or the valve. Another methods which we can use is to use an intravitreal triamcinolone, as I showed you earlier in my video. So that will help us to make sure that there is no residual vitreous. Next option is to make sure that your bevel is up. So when we cut the tube, make sure that the bevel is up. That also will help to up to an extent the blockage of the tube. The other complications, intermediate and late complications, include the retraction of the tube. So usually in pars plana, we leave quite a good length of the tube, around 3.5 to 4 millimeter length of the tube can be placed into the pars plana. And of course, the tube or the pars plana clip exposure also is a possibility. I just want to share some of the success stories, which I've taken out from the literature. Now there are quite a bit of literature which is available. So I've just taken a few of them just to understand this procedure better. So this is a study done by Massinini et al., wherein he has done a study of 27 eyes of complex refractory secondary of glaucoma, of all kinds of glaucomas. Now his follow-up was quite a bit. It was average of 23.6 months. But the maximum follow-up was almost 36 months. So he found that in his study, he has used only Ahmed glaucoma valve. Now the intraocular pressure, it decreased from 30.2 preoperatively to almost 13 millimeter of mercury. So he has had a good success rate with Ahmed glaucoma valve, which was inserted via pars plana. The best part of the study is the follow-up which is there. Now, this is a study done for a Barbell tube placement. So this was mainly for a neovascular glaucoma. So this study's the highlight was the 89 eyes which he had studied, and the mean follow-up was around 20 months. Now, the preoperative versus the final IOP and the number of glaucoma medications was significantly decreased. Another interesting factor about this study was they had even compared the gauge, whether it is 25 gauge or a 23 gauge vitrectomy which was done, and whether there was any correlation with the success of the bare well tube placement, which I'll be talking slightly later. Now, this was, of course, my friend Dr. George is a part of the study wherein they have done an intermediate term outcomes of pars plana tube of Orolab aqueous drainage implant for refractory glaucoma. So they also found that pars plana is a useful procedure and they get good control of intraocular pressures in certain subset of patients. Now, second aspect I would like to say is about the pars plana vitrectomy gauge. There's always a confusion or people are skeptical to use a 25 gauge vitrectomy. So this was a study wherein they did almost 10 to 12 eyes. They did a study, and it was published in ophthalmology, where they did a combined 25 gauge vitrectomy and posterior tube shunt placement. So in this, they have used both Ahmed glaucoma valve as well as the bare weld implant. In both the scenarios, they found that 25 gauge vitrectomy with a posterior shunt placement, it was successful and there was no case of tube obstruction. So this shows that even 25 gauge vitrectomy will help us to put the tube placement into the pars plana. Now, this was the earlier study which I had mentioned. They had around 44 eyes wherein they had done a 23 gauge and 20 gauge, and around 42 eyes which they did a 25 gauge vitrectomy. So again, they found that both the cases, as far as the intraocular pressure was concerned, the success, complete success, or the qualified success was almost similar in both the groups. They found only certain complications like a rebleed, which was happening more common with a 20 gauge, which is already a retina study which has been established. Now, the third part is a comparison. Like there are studies where they have compared the pars plana versus the anterior chamber placement. So this studies, they have this study of 57 eyes they did, and the mean follow-up was 43.5 in pars plana and around 35 months in anterior chamber group. So what they found is number of post-operative complications, they were almost similar in both the groups. And if you see the Kaplan survival curve also, both pars plana as well as the anterior chamber, there was not much of a difference in the survival rate. Now, when we compare the same comparison in case of an Orolab aqueous drainage implant also, this was a study published from Arvind group. They also found that 84% in the anterior chamber group and almost 72% in the posterior segment group had a success rate. Now, there have been many studies comparing this, but many a time direct comparison between these studies is a little difficult because of the variable success criteria. Each study will have their own success criteria, different kind of a follow-up times, and many a times heterogeneous patient population, because some of their studies are only neovascular glaucoma, some studies are only post PKP eyes. So because of this heterogeneity of the patient population, direct comparison may not be possible, but we can definitely learn a lot from these comparative studies as well. Now, there is always a question whether to use a clip or no clip. So this studies wherein Parihar et al., Maris et al., and the Dias-Lopez et al., they have done the study with the clip, and they found the tube obstruction rate was around 10 to 12%. So this is a study which analyzes the without employing a clip. That means the normal FP7 tube or a Barwell tube or an RD tube, when we put it into the pars plana without a clip also, it was not much different. Probably one or two studies had beyond 20% of tube obstruction. So to conclude, pars plana is a useful therapeutic option for refractory glaucomas. You can choose any of the devices which I mentioned. And again, it has been proved that with or without clip will give us the best results. Thank you.
Thank you very much, Dr. Mina, for this nice presentation.
Thank you, Mohammed.
Any one of the panelists want to ask Dr. Mina any question?
Yes, Dr. Mohammed, I have a comment actually, if I can.
Yeah.
Sure.
Thank you very much, Dr. Mina, for the wonderful presentation. One of the clear indications that I use pars plana vitrectomy for is patients who are going for keratoprosthesis. I do Boston keratoprosthesis at home for patients with corneal blindness, where the success rate of natural PKP or cornea transplant is very poor, like patients with Steven Johnson or OCP or chemical burns, etc. And those patients, I think the only option left with you, if you are going for a valve, is to go for the pars plana approach, because of the very crowded anterior chamber and even the sulcus. So you will not be able to implant it anywhere else except the pars plana approach. Thank you very much. Very nice presentation. I learned a lot.
Thank you.
Thank you, Dr. Wissam. So just, we'll move to Dr. Yasmin Al-Sayed. Dr. Mina, can you just exit the screen?
Yeah.
Dr. Yasmin will
let me share screen.
Yeah.
Right, can you see my screen now?
Yes.
Can you see my screen? Yeah, okay. Okay, I'd like to thank the organizers for inviting me today. It's been a pleasure and a great honor. I've really learned a lot from all the speakers. My talk today is on complications of glaucoma surgery. Of course, complications of tubes, are kind of unavoidable. Of course, if you follow the precautionary measures and the excellent tips from today's talks, you're much less likely to encounter them, but it seems they're inescapable and you just can't get away from them. So I don't have any financial disclosures. I'll start with the intraoperative complications. And these are not too many, actually, from what we see and from what's been reported by the ABC study. What you would expect is some hyphema sometimes, and that definitely resolves. fewer cases of negligible complications like the sclera perforation that's in less than 1% of cases. So to me, a glaucoma drainage device surgery is basically a suturing procedure. So you're basically suturing and suturing the tube to the sclera, the plate to the sclera. But there are two steps intraoperatively where I stop and really focus. And the first step is when I'm taking the scleral sutures to anchor the plate to the sclera. So here you don't want to be too deep so as not to perforate, especially in eyes with thin scleras, the myopes, the ophthalmic eyes, and you don't want to be too superficial and risk having a loose anchoring of the plate and then possibly an extrusion over time. And the second step is deciding where you want your tube to go in the anterior chamber or sulcus and aiming at this position more or less exactly. So the main difficulty I run into intraoperatively really is having the tube exactly where I want it to be. That's in maybe 1 in 7 or 10 cases, it keeps on going into the wrong passage where you don't want it to go. I haven't used the trick by Dr. Senthil about using the bevel up or tilting the bevel up. For some reason, this Egyptian fellow never told me the trick before. But what I do is I use a syringe with viscoelastic, and I use this to guide the tube where I want it to go. You can tilt or press gently on the edge of an IOL to slide the tube anterior to it if you're aiming for sulcus. So this is an older video. Now I go for a bevel down in the sulcus placement of tubes. For this other patient, where I'm trying to insert the tube in the anterior chamber and it's not going in, obviously because of PAS, and it keeps on going behind the iris. So again, a needle helps in these cases, the syringe, just to guide it into the anterior chamber and possibly lyse some of the synechia there until it's safely in the position where I want it to be. So this is the main challenge I get intraoperatively. Now looking at postoperative complications, according to the ABC study, again, the 5-year results, the most common complication was corneal edema, and in around 20% of cases, and half of these were attributable to the implant itself. This is followed by diplopia, like Dr. Shang was saying. CME and iritis happen, but at a smaller rate, and shadowing of the anterior chamber at a range of 2 to 3%, and similarly for tube cornea touch, and then tube erosion at 1% for the Barvold implant and 3% for the Ahmed valve. So I'm going to be looking at some of these complications and a few more, and the management of each of them. And for the sake of this talk, I decided to order them in order of increasing dreadfulness. So I'll start with the ones that are least dreadful, at least to me, and then I'll end up with the ones that I really hate to face. So corneal touch is the first problem. And actually, it's not the touch as much as it's the corneal endothelial dysfunction, because sometimes you get the dysfunction and the localized or diffuse haze without even having a touch on the slit lamp when you're examining your patient. So it has to do with the eye rubbing, the squeezing of the eyes in the pillow at night, or simply blinking. And then the turbulence of the aqueous at the entry point to the tube causes some endothelial dysfunction as well. So, and in particular in pediatric eyes, where you aim at, say, a mid-iris insertion of the tube, in these patients, I find that because of the low scleral rigidity and the slight collapse of the globe when the pressure normalizes, the tube ends up being longer than what you originally placed it, and you end up needing to shorten it in a way. So for the sake of this, I prefer to do it by transfixing the tube with a syringe rather than expressing the tube through the main incision, unless it's a very long tube, but I'm more comfortable doing it by transfixation with a syringe. And in most of these cases, if it's a localized edema, it resolves over time. And now, the second complication is encapsulation, which ends up in the hypertensive phase. And there are multiple risk factors related to that. There are the patient-related risk factors because of the aggressive scarring potential, the device type, whether it's a valved or non-valved implant, and the device material. It's been shown that the polypropylene plate of the Ahmed's valve, the S model, scars more and leads to more encapsulation than the silicone plate. The role of intraoperative antimetabolites is more or less controversial, and and the post-operative steroids do contribute to less scarring, of course. So some of this encapsulation has to do with the early functionality of the Ahmed's valve, and that's been the main culprit of why it's been causing more encapsulation possibly than the Barveld implant. And this has led some to consider using very early treatment with aqueous suppressants as early as the first day post-operatively, and they've shown some good success rates. And I've started doing that lately over the past 6 or 8 months, and I'm happy with the results for now. So suppressing the aqueous in the early postoperative period prevents the gush of the aqueous through the Ahmed's valve into the capsule, and so it reduces the congestion that happens early on and predisposes to the hypertensive phase and later encapsulation. So the case I'm presenting with encapsulation today is an extreme case that has encapsulated to the extent of causing a lid deformity. So this was a boy that had an Ahmed's valve implantation for pseudophakic glaucoma, and his pressure was uncontrolled, obviously, but he came with this cosmetically annoying deformity. And this is not our patient, but I'm showing this bleb to show what kinds of blebs I would attempt needling in. So I would needle a translucent bleb, considering that it's a minimally invasive. It is actually a minimally effective procedure as well, but you can, it's just worth a chance whenever you feel that the bleb is translucent and that you can spread it over a wider area, especially in adult patients. I do attempt that because I don't need to take the patient under anesthesia. And what you want to do really is not just to perforate the capsule, because once you perforate the capsule, the aqueous spreads and you get a very nice diffuse bleb that scars within 1 week. But what you want to do is to lyse the adhesions around the capsule so that so you reduce the risk of them reestablishing later. Now, our case is different. So this patient has an aggressive fibrous capsule, and I've revised a handful of these. And every time I do, I get the feeling that I've perforated the sclera throughout the procedure until I get the first peak at the plate, because as you can see, the capsule is quite thick and tough and white. It looks like sclera exactly. And once you expose it, you expose the underlying plate, you find the nice filtration out there. One tip here is to always open on the side of the plate, never on top, because that would risk extrusion at a very high rate in the early and late post-operative period. Now, hypotony is usually self-limited and manageable. Of course, it can lead to disastrous consequences if it's not caught and managed timely. And in case of the Ahmed's valve, hypotony happens because of one of 2 reasons. So either the valve mechanism has a problem, because normally it opens at a pressure of 8. But Emma Jones and co-workers have published their work on some Ahmed's valve where they measure the closing pressure outside the patient's eye and found that the valve was faulty in the valve mechanism was faulty in some of these. But then newer medical revised this, and now they're much less likely to be faulty. But that's one reason to suspect if you get a low pressure after an Ahmed. And the other reason is to have leakage at the site of entry into the sclera. And whenever you suspect that, you need to stain, and you can take a suture or replace your tube altogether to avoid the early hypotony. Now with the Barveld, it's a different, and one tip here is that you need to really struggle to fit your tube into the sclera. If you find it sliding very easily, then it will probably leak, and then you need to test for a leak in these cases. It needs to go in forcibly and with some struggling. Now with the Barveld implants, well, with the Barveld implants, it's a different story. So with the Barveld, you create your own flow restriction, and sometimes you get disappointments. So in these cases, I go back and stent the tube using a 3.0 or 4.0 Prolene suture, Supramid if it's available, and make sure in these cases that you use a long enough stent, 2 centimeters at least, so it wouldn't slide back into the anterior chamber. Then conjunctival retraction, and conjunctival retraction here, the main culprit is closure under tension, and this happens mostly, I encounter it in patients who've had multiple glaucoma surgeries and scarring at the conjunctiva, even if it's in a different quadrant But having undergone multiple glaucoma surgeries, you sometimes find that it's difficult to close the conjunctiva. And even if you manage to do so, they're much more likely to develop conjunctival retraction in the early postoperative period. And small retractions can be watched. You can treat them conservatively and keep an eye. But for bigger retractions, you need to go in and revise them. And of course, you don't want to just pull the conjunctiva back in place. You want to dissect enough tissue posteriorly to free enough conjunctival tissue so it wouldn't be closed under tension. You need a very relaxed closure here. And I close with running locking sutures, even for the primary cases that did not get a retraction. So this is my routine closure for the conjunctival with 7/0 Vicryl. Of course, for bigger exposures, you need the help of amniotic membrane or conjunctival flap. Initially, if you can get one, because the flap comes in with its own blood vessels, so it's less likely to disintegrate than the graft, conjunctival graft. Now, tube displacement, and these are usually manageable easily, especially if they've been in the correct location for years. I just go back and replace them in their original position. So this girl has had the tube for a couple of years, and then for some reason it just went in and slipped into the PI. Could be that she squeezed her eye too forcibly. So for these cases, I don't do anything drastic. I just go in and replace the tube, hoping that this would keep it in place for another year. I mean, for a longer time. But for patients who've had this problem early on in the postoperative period, say in the first year, I would consider revising the whole tube position from the start. Another displacement is to go into the vitreous, and in these cases, the tube end will suck in the vitreous, and you need to do some anterior vitrectomy around it. Make sure that you pull the vitreous strand from inside the tube lumen, otherwise it will keep blocking it even if you replace it in the correct position. And then when you're happy that there's no vitreous traction or vitreous inside the tube, you can replace it into its original position. Now, the last and most dreadful, the winner, of course, is the tube and plate extrusion, because this can lead to disastrous consequences. I don't have suprachoroidal hemorrhages to present, but this to me is one of the things I really dread, is having a tube or plate extrusion. And this usually happens at the site where the tube dips into the sclera. So at the site where it's kinked, it elevates the overlying tissues and results in pressure atrophy over time. And with the advent of donor tissues and the introduction of new techniques like the scleral tunnel, the risk has been markedly reduced from as high as 30 to 5%. The chance of developing tube erosion in the TVT study was 5% at 5 years, and the ABC was 1 to 3% at 5 years. And the single most important thing to watch out for, what I teach the residents and fellows to look out for, is the site of entry of the tube at the limbus. This is the #1 thing I follow in the tube patients, because you really want to spot it early on when it's just eroding through the conjunctiva, because then you can manage it either with a patch or you can remove the tube altogether. But if it's not recognized timely, within weeks or even days, it can lead to disastrous consequences. So I'll finish this off with a patient, a 7-year-old boy that I've been following for years. He's had multiple glaucoma surgeries, starting with angle procedures, trabs, and then had a supratemporal Ahmed glaucoma valve. And then at some point, the pressure was not controlled, so I went for an infranasal Ahmed glaucoma valve. And 1 week later, he had a conjunctival retraction, exposing the patch. And I decided to follow him, but it kept getting worse. And by the first month, I went in and revised it like I did for the previous video. I won't need to show this again. But then again, a month later, the conjunctiva started to retract back, and now the tube itself was exposed, which is quite serious. So I decided to go in and patch the tube, a really messy surgery. And I hadn't seen the tube exposed at this location previously. It usually exposes anteriorly. And if you can see here, the conjunctiva was starting already to conjunctivalize and cover back the patch, but the tube itself was eroded, and the conjunctiva was very unhealthy, but I managed to close it. And then 2 weeks later, he comes back with an extruded plate. So at this point, I was suspecting that the plate was probably not properly anchored in its place. So I went in and decided to revise this or explant the tube altogether. But obviously the tube was well sutured to the sclera, and I eventually ended up removing the whole tube from the infranasal quadrant and implanted him with another one supranasally, sorry. So looking at one of the studies, one that I'm aware of that looked at the risk factors for tube erosions retrospectively in their cases. And interestingly, the significant risk factor for erosion was concomitant surgeries with the tube operation. They did not find that previous surgeries were a risk factor, which is a bit different from my own experience with this. They also found other factors that were less significant contributors to erosions, including dry eye and pseudoexfoliation. And then looking at the results of repair of these cases, they're quite gloomy. So you can expect half of these cases to require a second operation and around 1 in 10 to require explantation of the tube altogether at some point. So the take-home message here is that prevention is better than cure. If you follow the safety precautions, make sure you don't close under pressure, patch your tube, anchor it well, you're much less likely to run up into complications. But once you do, it's important to recognize them timely to be able to intervene properly. Thank you, and stay safe, everyone.
Thank you very much, Dr. Yasmin, for this nice presentation.
Thank you for having me.
Yeah, just I have one question. In cases of encapsulation, do you prefer to do bleb needling alone or together with the blebectomy?
With what? Antimetabolites?
No. I mean, bleb needling alone, or just you exist the cyst also. You do blebectomy also?
I do blebectomy for very aggressive scarring that's not responding to needling and that's causing a deformity. But if encapsulation ended up in only failure without a cosmetic deformity or any problem, I go back and to implant another implant or do a diol cyclophotocoagulation.
And in cases also of tube exposure, just you prefer to do another patch graft, or you close it with conjunctiva?
Tube exposure, you mean eroding through the conjunctiva? I have to patch it because this
Can you
area...
hear me, Dr. Yasmin?
Yeah, I can hear you, yeah. Okay, now we got interrupted. But for the tube exposure, yeah, definitely I need to patch these cases. So I use a corneoscleral rim. That's what we use to patch in most cases here. And then I make sure that the conjunctiva is properly closed with or without the help of a conjunctival flap, if that's possible. And sometimes an amniotic membrane.
Thank you, Doctor. One more question also in cases of shallow EC. Can you hear me nicely?
I do.
Yeah, in case of shallow EC, I mean, how can you prevent, tube corneal touch? Is there any maneuver you are doing?
I don't leave them shallow for a long time. So I go in and intervene. And as I showed, so usually I do form them with cohesive viscoelastic. And if I'm suspecting that this will happen again, I do stent the tube. And sometimes if this is recurrent or I think that the stent wouldn't be enough, I will go in and ligate the tube altogether with a vital suture that would dissolve later. But I have to really know what the reason for the hypotony is. So if the valve is not functioning, say, which is very unlikely. I mean, I've read about, but I've never noticed the case. I've never ran into a case of Ahmed glaucoma valve where the valve dysfunction has led to chronic hypotony. But eventually I have to know what the reason for the hypotony is. And being more common with the Barvold, I go back and re-stent them or re-suture the ligature.
Thank you, Dr. Yasmin. Also, just I want to ask the panelists about their experience with the hypertensive phase. We can just start with Dr. Mina. Dr. Mina, are you there? Dr. Mina, can you hear me?
Yeah. Yeah, can you hear me?
I want to, yes, I can hear you, yes.
Yeah, so a hypertensive phase, yeah, usually it is managed medically most of the time. Hypertensive phase, yes, gets resolved with the medical management. So we short period of time with an anti-glaucoma medications, most of the time we can manage the hypertensive phase. Generally, a surgical intervention, I've not really done any kind of a surgical intervention unless and until it is severely encapsulated bleb, where we do in case a bleb needling, or as Dr. Yasmin suggested, a capsulectomy has to be performed. Otherwise, usually it gets managed with the medical management. Anybody else
Thank
can
you, Dr.
add
Mina.
on? Probably George will be a better person to talk about an ADI or a non-valved, but which is not common in that.
Yeah, can I add? Yeah, so I agree with Dr. Yasmin that we definitely have to prevent it. I think prevention is very important, and all of us have learned it. So we start the anti-aquasuppressants as early as day 1 or day 3, depending on what the early postoperative pressures are. That to a significant level has decreased the hypertensive phase. Having said that, despite all that, we do see hypertensive phase, and most often medically we can manage. And I would say that in my practice, close to about maybe 1% of patients require a repeat intervention. When I say repeat intervention, so I used to, 10, 12 years ago, I used to do just a needling. And like what Dr. Yasmin showed, go and try and cut the bleb capsule as much as possible. They do very well, extremely well for the first 1 month. And after that, they go back to encapsulation again. So then we do the bleb wall excision as well. So recently, in fact, we've just submitted a manuscript. What we have done is, so we do a non-valved implant and things are okay, leave that aside. But if you have done valved implants and we are struggling with this bleb encapsulations, one of the things that we have done is we go and try and destroy the valve. So basically you go not just remove the capsule, the fibrous capsule, but also destroy the valve and make it into a non-valved implant. Try and ligate the tube as well. So basically, because you have destroyed the valve, you don't want a hypotony. But the other concept is that after we destroy it and when we ligate it, when we close the conjunctiva back, once the ligation opens up, it's apparently supposed to work like a non-valved implant. So this particular thing, we've done it in the lab. And it has proved to be helpful, and we started doing it in some patients. So I have a preliminary experience of doing it in about 3 patients for now, but then at least of the 3, I can say there was one lady who was doing extremely well. It was post-vitreoretinal surgery with a 360-degree encircling band, very difficult conjunctiva. And so 1 implant and then a diode CPC twice, but still not helpful. So the 3rd time, if I had to take it up, there's no place to put another implant there. So this particular procedure seemed to have helped very well. And the other 2 patients are back on a couple of medications, but they are still okay. So it is still very early for me to say that, but this is one thing that we can try and do. Other thing is, if it fails and we'll have to do a second implant, then obviously choose a non-valved implant, because you know that encapsulation is quite high and it's going to be very thick in these patients. So might as well avoid using a valved implant.
Thank you, Dr. Sirisha. And I have a question for you. I mean, you prefer to do, if the patient needs second surgery, you prefer to do a trap post-EGV, or you prefer to do another implant in another place?
Yeah, so if the question is, why did we first do an implant for this patient? So if it is because of a terribly scarred conjunctiva where the trap was not possible, then of course, the second procedure is going to be an implant. Or sometimes I buy time, I do a limited diode CPC and then continue them with medications. And if that doesn't work, then going for a second implant. Or if the conjunctiva is not so bad, even if it means that you have about 4 to 5 millimeter or 3 millimeter conjunctiva supranasally, I still would prefer to do a trap before going in for a second implant. So second implant, I am a little skeptical. So it's not that we don't do it, but have we exhausted the other procedures before we choose to do a second implant is something that we always have to think. At least for me, that is what it is.
Thank you, Doctor.
Dr. Muhammad, if I can comment on this?
Yes, yes.
Yeah, now with the era of the micropulse cyclophotocoagulation, I'm having a lower threshold to go for that if I want to boost the function of my tube. We know that it's a relatively gentle procedure in comparison to the standard CBC in terms of postoperative inflammation and complications. So I'm having really a lower threshold now to do micropulse cytophotocoagulation following tubes if my tube is not reaching the target pressure I'm aiming, rather than going again and putting a second tube.
Thank you, Dr. Sam. Dr. George, are you with us?
Yeah, I'm very much here.
Yeah, I want to ask you the same question, your experience with the hypertensive phase, since you are doing a non-valve implant in most of your cases. How much?
So basically, because of the higher profile and the lower surface area of the valved implant, the AGV, they tend to have more hypertensive phase and more T-nonces in the postoperative period. One thing you need to know here is the inflamed aqueous goes to the Ahmed glaucoma valve very early in the postoperative period. The hypertensive phase we are experiencing with the Orolab aqueous drainage implant is much more delayed. If you see the hypertensive phase of the Ahmed glaucoma valve, it happens somewhere between 4 to 6 weeks postoperatively. Here we are seeing 8 to 12 weeks postoperatively. We get much more thinner blebs, much more low profile blebs, larger surface area. But it still does not mean that we don't see hypertensive phase. We approximately see hypertensive phase in 30% of our non-valved implant patients, but the difference is it's very self-limiting. With additional aqueous suppressants, almost all of these cases come back to normal by the 4th, 5th, or the 6th month. So I have frankly not done any interventions for a T-non cyst in a non-valved implant. And much earlier in my career, I have done a few cyst excisions for thick T-non cysts for Ahmed glaucoma valve. And initially we used to aspirate those cysts. Then we went in for needling, and then finally the cyst excision. And we also used to give a little bit of mitomycin wash during that cyst excision for the post-Ahmed glaucoma valve T-non cysts. But one thing is for sure, hypertensive phase does occur with non-valved implants, but much less severe than the valved implants and amenable to medical therapy.
Thank you, Dr. George.
I have a question for the panel. Dr. Mohammed?
Yeah, you can go.
Yeah, does anyone have experience with ligating the Ahmed's valve to avoid this encapsulation, reduce the risk, to avoid the glaucomatous aqueous from reaching the bleb early on? No, because I'm willing to try that.
I have done it in a couple of patients. That is primarily, like I was sharing, it's in aphakic glaucoma patients where you don't want a sudden hypotony, although we know that valve implant itself is supposed to prevent that hypotony because it restricts. Having said that, any decrease in intraocular pressure in these eyes can behave differently. So I've done it in a couple of patients, but I really didn't see that the bleb encapsulation did not happen. It did happen the way it normally would, but like in a non-valved implant, it was slightly delayed. So that apart, but other thing I wanted to add is to what George said, we do see hypertensive phase with non-valved implants as well. And I have had two patients, especially children, two young children I can remember, I think age one was about 10 years and the other one was about 16, 17 years. Both were glaucoma and pseudophakia, and these children had so it was the primary surgery as after the trab had failed. The primary implant was the non-valved implant, but they had such severe hypertensive phase that the bleb wall was so thick that I had to go and do a bleb wall excision. So in fact, I've sent it for histopathology. And I thought that once we do the bleb wall excision and then religate it, once the ligature opens up, it should settle down. But this child came back again and she required a second implant to control that pressure. So it's extremely rare, but it can happen. And I don't know why. And she also had galactosemia. So whether it's something to do with the systemic problem or the generalized inflammation that she has, I have no idea. But there were two cases for which I had to do the bleb wall excision. With the second implant, also a non-valved implant, that settled, the pressure settled down very well.
You know, and these are
yeah, continue, Dr. Said.
Yeah, in these aphakic and pseudophakic patients, we've had very good experience with angle surgery, circumferential angle surgery. So it's already been published on circumferential microcatheter trabeculotomy by Sharon Friedman from Duke Eye. And we're about to publish our study on another technique for circumferential trabeculotomy, and they do really well. The success rate was quite high. Unless they have very aggressive PAS, I wouldn't attempt that. But even the patients that we originally used to do trabs and tubes for, and now they have a failed tube, we go back and do angle surgery for these, for all available parts of the angle, either ab-externo or sometimes GAT if it's a fresh eye, and they do really well.
Yeah, agree with you. But both these kids had extensive peripheral anterior synechiae. In fact, they've both had secondary IOL implantation, and you can understand the problems that are there with them. Yeah, but that is a very good option.
Just to add on to the one query what Dr. Saeed was asking about ligating Ahmed glaucoma valves, there is also this fear that the valve may not function. The valve mechanism may not function once the tube ligature suture dissolves. So that's also a concern. We are not sure whether the valve, because we are priming the tube, we are priming the Ahmed glaucoma valve, and then implanting it, ligating it. There's also a concern that it may not open up when the
I see. That's a great point you raised. Yeah.
But to counter that, we have a lab where we actually work on the flow characteristics of AGV, and we did try this because this was a question that I had asked a couple of consultants when I was visiting, and we don't have an answer. Because we don't have it, and then we tried doing this. Actually, when the ligature opens up, you don't have to prime. But the fluid drainage takes a little time. It's not like it starts flowing immediately, but it takes maybe about a couple of days for it to start filtering once the ligature opens up, but it does work. So George, we've tested that in the lab.
Interesting.
Thanks, Risha.
Thank you.
There's a question here about post-valve diplopia, how to manage. Any special management?
Easy. I refer to a strabismologist.
I had one case actually, just to mention that it was an VKH case, and after the tube, she got like a severe diplopia, vertical diplopia. So I referred the patient to our uveitis specialist, and he advised to add to the topical steroids, to add systemic steroids. And actually, the patient improved 5 days after that, and the diplopia just go away.
Interesting.
I think the management differs whether it's a mass effect from the bleb or if it's a muscle tension effect from the muscles being lifted up. So if the eye is deviating toward the plate, then it's the muscle being lifted up. And if you do an ultrasound, like Dr. Surisha's beautiful pictures, you'll see the very large bleb incorporating the extraocular muscle, usually the lateral and superior recti muscles, and lifting the eye up and out that way. In those cases, the one thing I do in clinic to see if the bleb or the implant itself is responsible for diplopia is, number one, I ask them when the diplopia happened. Did it right after surgery, or was it when the tube opened? And number two, I would tap the bleb and immediately measure the angle of deviation before and after I tap the bleb. If it improves a lot, then you know it's due to the bleb. And stepwise, one thing I found to be useful to tell the patient is that about half of those patients can get better on their own without intervention, okay, up to 6 months. But their angle has to be smaller and smaller each subsequent visit. So that's one of the few times when I take the time out and actually map out the primary and secondary deviation in these patients. A lot of the times you end up having to collapse the bleb, and that means ligating the implant or putting a stent into the lumen to decrease the bleb size. And lastly, it's always important to set the expectation that if we can get their eyes close enough, but not have them align enough to fuse, they might need muscle surgery in the contralateral eye to bring the eyes into alignment and allow Herring's law to bring both eyes into primary position. One thing I've been doing recently with fair success is I do whatever I can with the glaucoma implant to get the eyes to be as close to each other as possible. Then I try to convince the patient, if they're phakic, to have extreme monovision IOLs put in. So one eye will have refraction for distance, and the other one will have a postoperative refraction deliberately about -5. So they have a near point up here, and the images are different enough that they can suppress one versus the other, and they have the added benefit of not having to wear presbyopic lenses. And that has made several patients quite happy. And it's one of those things that you can test by putting them in spectacles that has monovision refraction before you commit them to the IOL surgery. So you get a sense as to whether this is a satisfying solution or not, whether the patient is going to be happy or not. But all in all, I think postoperative diplopia is always difficult to acquire. And it's easy to remember that a lot of the glaucoma patients who have very poor peripheral visual field, they don't have any fusional amplitude. You deviate their eyes a tiny bit, their eyes want to stay apart because they don't have the peripheral visual field to bring the eyes back together. So we're putting implants in a group of patients who are particularly high risk of getting acquired diplopia after surgery.
Great.
Thank you, Dr. Peter. One question from Dr. Muhannad Al-Badour. He's asking, do you excise tenon capsule while inserting the Ahmed glaucoma valve? For all panelists, if anyone is doing like that.
Not really. We want the tenons there because we want the conjunctiva and tenons to heal well. So we don't do that as a primary tenonectomy is not performed.
And about using of mitomycin in Ahmed glaucoma valve in congenital glaucoma.
I can take that question also. We don't use mitomycin C, but I know that people in move fields do that routinely. So they use it for about 5 minutes along with bowel. But what they do is differently is that they do, apart from the tube ligature, they also stent the tube with Supramet. So that as soon as the ligature opens up, they still have another, the tube occlusion is still there. They don't go into sudden hypotony. So that's the only experience that I have heard of. But otherwise, we don't use mitomycin for any of the, neither for the children nor for adults. Anyone else does it?
I just can't resist not to use it, although all the evidence is pointing that it doesn't really add much, but I just can't get myself to stop doing it. I did for a while, and then for a good month, I had very disappointing results. And so that and Plaquenil, I'm going for those too, despite the unavailable evidence. I just can't stop using it. And definitely with needlings and as an adjunct, I use mitomycin.
Thank you.
Thank
you. Thank you, Dr. Yasmin and Dr. Srisha. Thank you all for this nice webinar. Actually, it was a wonderful and amazing webinar with all gens of glaucoma surgery, and we learn a lot from you. I think we come to the end. So thank you very much. We'll see you again in a new webinar, inshallah.
Thank you very much.
Thank you.
Thank you,
everyone.
Thank you.
Bye.
Bye.
Bye. Have a good day.
Bye.